Good morning, everyone. Welcome. I'm Amanda Smith, one of the planning committee members for the wellness workshops. Thank you for joining us at our virtual wellness workshop and for logging into the Zoom webinar. Please be aware that this session will be recorded and made available through website/social media links to inform and educate the public on this topic. Therefore, keep in mind if you choose to participate in an identifiable way, you acknowledge that your name and/or video will be recorded and you are authorizing the use of your information in the recording as described. You have no obligation to speak during the recording. The recording of today's workshop is protected by copyright law and is not to be copied. Once again, I'm Amanda Smith, one of the members of the planning committee for the wellness workshops. The wellness workshops began 10 years ago to support mental health professionals and community members in Denton County who work with children, youth, and families. As the wellness workshops have grown, we have begun to support mental health professionals all throughout North Texas and beyond. Cook Children's Center for Community Health launched the Thriving Communities Collaborative in 2023, which brought together community partners with the same goal of improving children's health in North Texas. This group focuses on mental health, caregiver support, healthy lifestyles, and asthma. For more information on the resources and education that is provided by the Center for Community Health, please visit our website using the QR code on this slide up in the upper right-hand corner. All right, so we have many people to thank for working collaboratively to put this event together. We'd like to thank the members of the Wellness Workshop Planning Committee, Cook Children's for providing CEUs, and you, if you've attended our previous events, for providing feedback. We planned this program with you in mind. We'd also like to thank each of our speakers for giving their time and sharing their expertise with us today. With their permission, we will post the slides and video from today on the Center for Community Health website for ongoing CEUs. As a reminder, you can find past webinars on the Center for Community Health and the Center for Community Health website, and they're available to earn CEUs for some of those also. We'll put the link for this in the chat. So if you did not receive the meeting packet with the presenter slides, you can also find that on the link that will be placed in the chat. Once on the website, you'll navigate to the Mental Health tab and then find today's presentation and click on Download PDF. So that should be popping up here pretty soon. All right. So here's a few housekeeping details. So I'll be hosting the workshop today along with Aaron Walter. We invite you to engage with the speakers in the chat box using the Q&A feature or by raising your virtual hand. You can talk with the group as a whole or one-on-one by clicking on the button next to the To field in the chat feature. This is located just above where you type your message. We'll have time for questions throughout the presentation. You can again use the Q&A box to ask your questions, or if you'd like to speak live, you can raise your virtual hand and we'll unmute you for you to speak directly to the speaker. All right. So today we will discuss the truths and myths of ADHD and the ADHD protocol in a pediatric setting. Interventions in the home and at school. We will hear someone share their personal story of living with ADHD, and we will finish with evaluations. We do not have scheduled breaks during our time together, but we will pause periodically to take questions. Feel free to take breaks during this time or whenever you may need. So by attending today's workshop, you will be able to summarize common myths associated with ADHD diagnosis, recognize symptoms of ADHD, identify medications used to treat ADHD symptoms, discuss the PCP's role in medication management and treatment of ADHD, and last, describe at least 4 intervention strategies to support children with ADHD symptoms at home and school. An evaluation link for today's event will be shared at the end of the program. Everyone is encouraged to complete the evaluation, and it is required to receive your continuing education credit. Today's speakers have no conflicts of interest to report regarding today's presentation. Right. So I'm now pleased to introduce our first speaker, Dr. Amanda Gray. Dr. Gray is a licensed psychologist and school psychologist. She worked at private practice and public schools, as well as in hospitals, private practice, and counseling centers before opening her own practice, Gray Area PLLC in McKinney, Texas. At Gray Area PLLC, Dr. Gray offers a range of services from evaluations to counseling and executive functioning training for individuals of all ages, as well as navigating supports for students in and out of school, presentations, and trainings. She specializes in a range of psychological, educational, social, and behavioral difficulties, but especially ADHD, anxiety, and autism spectrum disorder. Thank you for joining us today, Dr. Gray.
Thanks for having me. I'm looking forward to it. Okay, I'm going to get my screen shared. Hold on. So we're going to be talking about the truths and myths when it comes to ADHD. So there are all kinds of myths that people with ADHD live with. A lot of it is stereotypical and can be very frustrating for them. The idea of they won't do something versus they can't do something. We see that a lot with a variety of things, but especially when it's something they're interested in versus something they're not interested in. That can make people think that they're lazy. And basically they're like, they can't possibly have ADHD because they can focus on video games or whatever along those lines for hours, but you can hyper focus on an interest and have trouble focusing on other things and still have ADHD. There's a myth out there that hyperactivity is the only form. Some people still don't think ADHD is real, that it's a choice, and that if they just tried harder, it would all work out for them because other people can focus easy, so why can't they? Other myths are that it's bad parenting. It's a male-only diagnosis. Only kids can get it. It's overdiagnosed. You're likely to abuse drugs if on medication, and accommodations for attention problems are unfair. All of those are myths. So some facts that we know, ADHD was actually first described in a textbook all the way back in 1775. It's something that is recognized by APA, the National Institutes of Health, the Department of Education, so it is widely known and accepted as a diagnosis. It's also highly genetic, but they can't pinpoint all of the reasons as to why. But most of you know that you'll see traits of yourself in your kid if you have it, or you'll be in meetings with parents and they'll start to discover that they sound just like their kid as you're talking about everything. So there's definitely a trend there of there being a genetic component. It's something you're going to have for life. It doesn't go away. You learn better strategies. You hopefully find a career that fits that type of attention, and it becomes less obvious to people, but it's always there. At least 90% of people are diagnosed via best practices, which is actually a really high percentage. But most people think the opposite, and that's why there was that myth of it being overdiagnosed. We've gotten better and better at our diagnostic criteria and identifying it. You used to have to be under the age of 7, then now we're under 12, and there's even adults that still get diagnosed later in life. So we're getting better at identifying it. Some more facts for you. Females get it too. There's way more research that's actually needed into that. In childhood, the ratio is about 2.3 boys to every 1 girl, but by the time you hit adulthood, the ratio is equal. That's kind of interesting because that means that females aren't actually identified until much later, which means they don't actually understand what's going on and why they're having the struggles that they are until they're much older than boys are. Like I said, we don't know the exact biological causes. There's not just one test you can give and go, yep, you have ADHD, you meet all the boxes. Now, I understand you can go to certain doctor's offices and they might have you and a teacher fill out a Vanderbilt rating scale, and that's a symptom checklist, basically. But there are lots of things that can cause those symptoms, and so trying to get the most comprehensive picture of the individual across settings is the best way to make the diagnosis. There's also a myth out there that it's an American thing and it's not everywhere else. Now, granted, there are cultures that highlight it more than others, just based on the way the culture is organized and developed, but it's not an American thing only. 5 to 6% of each population around the world have a diagnosis or could have a diagnosis of ADHD. It's based in brain chemistry, not bad parenting. So there are still people out there who will tell parents that it's not a real thing and it's just that they don't know how to parent their kid. And it's just not the case. Now, the more strict we are on someone with ADHD, it can cause more problems because we think that they can do something, and so we're writing their case about it when they need to approach it in a different way. I like to explain it as it's like being left-handed in a right-handed world. You can still do everything, but the world's not always built for you, so you have to adapt and make it where it's something you can do with more ease. You can hyper focus on some things and lack focus on others, such as the video game comparison I made earlier. I personally feel like a deficit of attention isn't really the appropriate title for ADHD. I think it's either dysregulated attention or a surplus of it. If you walk into a room and everybody is talking, or you go into a Mexican food restaurant on a Friday or Saturday night and everything is loud, you might be paying attention to everything that's going on in there. So you're getting pieces of information from all of these different conversations rather than just the conversation you're having with the person across from you. So there's too much attention going to too many things, resulting in too little attention to the thing you're supposed to be focusing on. Untreated ADHD is actually what's more likely to lead to self-medicating and addiction than actually being on medication because you're trying to figure out how to cope with the struggles that you're having. That does not mean that everybody that is untreated with their ADHD is going to be an addict, though. And accommodations are necessary for many with ADHD. It goes back to the example of being left-handed in a right-handed world. Sometimes you just have to approach it a little bit differently, and accommodations can help with that. There are plenty of famous people out there with ADHD. I've only listed a few here. I actually think Richard Branson, if you're not following him on LinkedIn or any social media platform, you should, because he also has dyslexia and he is constantly posting things about hiring neurodiverse individuals and how much benefit there is for corporations or any kind of business structure. And it's pretty inspiring to see everything that he's been able to do. Michael Phelps has ADHD, Simone Biles, and it's been suspected in Benjamin Franklin, Lincoln, and even Mozart. Kind of an ironic time for me to have this slide in with all of the trouble with airports right now and that kind of thing and understaffing. But on average, there are 16 million flights the FAA is responsible for per year as of 2023. So the reason I'm using this as a comparison is this is a lot like what it's going to be like for somebody with ADHD that has executive functioning deficits. So there's an average of 45,000 flights a day managed by the FAA, which is a daily average of 2.9 million passengers. So in Thanksgiving of 2024, there was an expectation of almost 6 million people flying just within the United States alone. So for somebody with executive functioning deficits, is there every day between what's considered average for air traffic control, managing all of these planes at once, and not average of Thanksgiving, whereas everybody else is just like a typical day or less. So basically, is the demand higher and their brain acting like air traffic control all of the time? And is that leading to the emotional dysregulation, the fatigue, the anxiety, and that type of thing? There's a good argument to be made there for that. So what's it like if you have ADHD? You can read and not know what you read. Most of us have done that at some point in our lives, but it happens more often when you have something like ADHD with executive functioning deficits. You may be reading the same line 15 times, the same page 15 times. It doesn't matter. You know you read it, but you have no idea what you read. Being distracted by everything going on around you. The air conditioning just clicked on, the phone vibrated. I can hear people walking in the hallway. It doesn't matter. Anything like that can be distracting. Another example would be for those of you that might do evaluations and stuff, if you're writing up a report and you're trying to look at scores and then you're trying to write up over here, just the act of flipping between your monitors and stuff, that might be a lot of demand at once and you get confused and have a hard time remembering from one thing to the next. Regulating how much you have to do of something or not. Does everything have to be done right now or does nothing? And sometimes your brain's going to trick you on that and tell you nothing needs to be done right now and you have plenty of time. And other times your brain's going to trick you the other way and tell you absolutely everything needs to be done right now when it doesn't. Thinking a task takes you some time, but it takes way longer. So I only need this amount of time to make sure I get out of the house in the morning. For any of you that are parents, and your kids are not good at this, you'll know because it's like right before you're supposed to be leaving that they all of a sudden decide it's time to get in the shower. It's that kind of thing. And then realizing that took way longer than I thought it was going to. Trying to switch between two different tasks and not actually getting either one done because you spend so much time just shifting your attention. The example I gave earlier, like the Mexican food restaurant or going into a crowded room, walking into that room and hearing some of what everyone is saying. Or as someone myself with ADHD, my family can tell you this, if we're playing a game and everybody's adding up their score and they're doing it out loud while I am also trying to add, that drives me bonkers because I'm hearing all of their numbers and I can't focus just on mine. The article that's cited at the bottom is also at the end of the slides if you ever want to look it up. But I thought that this article was really interesting because it was about a teacher and another early intervention specialist that did a simulation of executive functioning deficits. So the quote in there from them was, "The task seemed simple enough. Just move a basket and catch falling shapes on the computer screen. Except the directions kept changing and the shapes kept falling, and no matter what I tried, they didn't slow down and I couldn't do everything at the same time. I failed at the task repeatedly. I felt helpless." That relates so much to so many kids that we have with ADHD. They're switching between, however many classes a day, 7, 4 if they're on a block schedule, and they're trying to shift their attention all the time. And all the expectations are different from one class to the next. It's the same idea of trying to catch all those shapes and the rules changing all the time and feeling like you're failing repeatedly. For some people, they're going to be the ones that interrupt in class regularly. They act and then they think. Leads to the same mistake happening over and over again, even though you've already addressed it with them. A lack of a filter, so maybe talking about something that's not appropriate for the situation or, speaking before thinking. Upset by things that seem small to others or that you shouldn't be upset by. So sometimes the tiniest things set somebody off, and they might even have the awareness that that shouldn't have set them off. But in those moments, the logic does not override the emotion. That idea of everything has to happen now, nothing is important. Which one of these is actually true? Which one can I trust in my brain? I hear parents all the time contact me and they're like, they'll just sit there and stare at their computer screen and they're not actually starting anything. It's not that they're really not starting it. They've sat down and they want to do it, but they cannot figure out how to do it, how to get started on it. And so it looks like they're doing nothing because nothing is being produced, but their brain is like a computer that's overheating and the fan is starting to circulate on it. And now you've got the wheel of death. That's essentially the equivalent of what's happening. There's also significant indecisiveness, asking them, what do you even want for dinner? Even giving them choices and them saying they don't know. Going somewhere you've been 500 times and not being able to pick something. If you finally get the ability to do something, such as the kid that's sitting in front of their computer trying to get their work done and not being able to produce anything, they finally get going on it and someone walks in and interrupts them, they can get very frustrated and might react emotionally or in a way they wouldn't normally. Everything feels urgent, so everything seems not urgent to people watching you because it just feels like everything you're drowning in all the time. Some kids, they're always late or always early. They overcompensate because they know they struggle with time. So now if they're not 15 minutes early, they think they're late. Or the time blindness is causing them to always be late regardless. Any of you that are parents and have had to buy multiple water bottles or lunch boxes or anything like that know that that can happen a lot, that it just gets left behind. We don't know where it got left because we don't always put it in the same place. Or if they are like me as a kid, we get these stacks of paper, all of which need to be signed at the beginning of the year. Seems like such a basic task. Put it in your backpack, take it home, get it signed by your parents, bring it back and turn it in. But if you really think about the number of steps that involves, there's way more to it because you have to put it in the same place, in the same folder. You may get that folder out more than once. You need to remember it all day long. Remember to take it out again and get it signed. Remember to put it back in, then back in your backpack, and then do all that again to turn it in later. And so not being able to do that when everybody else can be really frustrating to someone. It also could make it where their backpack looks like a bomb has gone off in it because all that paperwork that was supposed to be signed is at the bottom of their backpack and you don't even find it until the end of the school year. Getting on task, something getting you off task, like the being interrupted example, and then not being able to get going again. And that also leads to increased emotionality in some kids and adults. This can cause set shifting and transition time to be difficult. So an example here is you've just finished doing the budgeting for a week. You're short on time, so now you need to write a report for work, and you find yourself struggling to switch from one type of task. First one was math with budgeting to another, a literary one. So you're shifting your attention again, just like students who are having to shift from English into math, into science, into social studies. Set shifting is the idea of rapidly changing to match all those new circumstances. That's not easy for everybody to do. The same rules do not always apply from one task to the next. So in the class switching example, yes, there's some basic rules that are going to apply no matter which class you're in, but that doesn't mean that everything else is the same. The way you solve a problem in your geometry class is not going to be the way that you solve a problem in chemistry. This can cause mental lag and it can be frustrating. So it's that example again of the wheel on the computer of death. There nothing is loading and the fan is circulating because your brain's just not quite catching up to where you are. And it can also cause problems because if you're not shifting the right way, you might be trying to apply strategies that worked in one setting to this next setting and it doesn't work. And that's also going to increase frustration, emotionality, and honestly lead to people giving up a little bit more. So some real life examples. So as someone that was a school psychologist for a while, it could be me sitting down to write a report and then switching to go to an IEP meeting, but I was in the middle of writing the report. Or for someone else, it could be that you're working on a report or something at your desk and then you have to go into a staffing or into another type of meeting. You have that momentum of doing it, and then you get called to help with something such as behavior in a classroom down the hall or anything like that. Then you try to get focused again, and it's not that easy. For some people, it is that easy. They can go home and be like, I need to do this, and they sit down and get it done. For other people, they know they need to do that, but their brain doesn't work that way. And it's frustrating, in all honesty, to watch other people who can do it so easily when you can't. So much of it, I guess the best way to put it is seems common sense and like something everybody should be able to do. And the older you get, the more you start to realize that other people can do things that you aren't doing as well. And that's where we start to see kids internalize it more, which is why intervening earlier to help them with it is more beneficial. You can also have trouble with inhibition. So if you're working on a training, in a training like this one, and if it was a group one in person instead, and you can see someone in your line of sight watching your favorite show, for me, that would be Friends, that's really hard to ignore. Your eye is going to naturally dart over to it. Same thing anywhere else you are, if somebody's doing something or people are talking about something you're interested in nearby. Trying to suppress that or suppress responses that you have is mentally exhausting. So if everybody has a capacity to deal with things, these things all chip away at it, and there's more that chip away when you have ADHD, leaving a smaller capacity here before you might flip your lid. Because it's already exhausting to do the task you need to be doing before you add in all of the other pieces. Updating and working memory. So in this example, it's time to get to work on a project, and you have a detailed outline showing which project components must be completed before the end of the day. However, when evening comes, you realize you only finished a few sections. So your brain in that process wasn't keeping your working memory updated and informed of changes, that you're not exactly where you think you are. So the evening ends, and then you're shocked that you didn't make it as far as you thought you would. Another example of this, though, is I've got kids that'll fail all semester, and then all of a sudden they're going to get a 70 on something, such as a semester exam, and they think that they're all of a sudden passing, even though they had failing grades up to that point. And so it's like it resets and says, oh, well, since I passed this one, I'm passing everything. So that was over updating your working memory without accounting for all the other things that were making your grade be low in the first place. It can also result in ADHD paralysis. So you really need to get things done, but you just can't seem to get the ball rolling. You're overwhelmed, frozen in place, and can't even think about what to do first. That's exactly what ADHD paralysis feels like. Being overwhelmed by emotions, information, surroundings, your brain freezes. That's part of what happens with those kids that sit down to do their work and they're sitting in front of the computer and nothing is happening. The brain just gets stuck and it's hard to move past it. So there's different kinds of ADHD paralysis. There's mental, which can cause your brain to crash, the computer wheel, all of those things. You have trouble processing information and organizing thoughts, can make it hard to know what to do or say next. There's choice paralysis. So it's the idea of how do I make this decision? And then you're overanalyzing it. And what if I don't like it? And what if I don't like the meal I ordered after all? Or what if I make the wrong choice? One of the ways I like to explain this is for any of you that have ever been to the Cheesecake Factory or BJ's Brewhouse, but especially the Cheesecake Factory, their menu is spiral bound. It is so many pages, and there's like at least 6 pages, it seems like, that are cheesecakes alone. And so there's about 30 pages that seem to be appetizers and meals you could choose from. That's overwhelming. That's a lot of choices to pick through. So on a day where our capacity has already been chipped away at, like I've talked about, and this is what we've got left, you could go through a drive-through with a kid that has ADHD. You go to, let's say, Cane's. They have what? 10 different options on the menu, but in reality, it's you get, chicken strips or a chicken sandwich. It's just a matter of how many strips or how big the meal is. And now you go through that drive-through with them, and that Cane's menu all of a sudden looks like the Cheesecake Factory menu. It's overwhelming. You could have taken them there 500 times before, and they might order the same thing every time. But now that ADHD choice paralysis hits, and they look at that menu and they can't make a decision. They don't know what they like anymore. They're worried about making the wrong decision. A lot of times this will lead people to go, never mind, I'm just not going to eat anything. And that can happen in all kinds of different sectors. So doing schoolwork, trying to get chores done around the house, trying to manage schedules, anything. They'll overthink and overanalyze all of it, and they'll just shut down. There's also task paralysis, hesitation, fear, or lack of motivation to start a task. People will come in a lot. I do a lot of kind of executive functioning training with kids and adults, even in college or beyond, where we're talking through all these things that they'll be like, I just have no motivation. But then when they're talking to me, it's not really no motivation. They wouldn't be talking to me if they had no motivation because they wouldn't want to work on any of this stuff. So they are motivated. It's the execution that's the problem. It's like they're stuck. This happens a lot if it's a new task or if it's very complex and intricate, especially if it's something that they don't think they're as good at, whether that's writing a paper or anything. Being bored also causes this, though. So it has to be the right amount of energy needed for it to work. Otherwise, it's too little or too much, and everything starts to shut down. This leads to a lot of procrastination. And this is also why you'll see some people who say they do way better when they procrastinate because the pressure is on them. So it's like the task was not hard enough. Now I've procrastinated and it's due by this time and I need to be done. Now I can execute it like no other. But that doesn't work for everybody. So some real examples for you. Some of these are my own examples. So I've emailed staff that I work with and tell them that I prepped different protocols without specifying what the actual test was, thinking they knew exactly what I was talking about. Kids will do this a lot and just start talking about something and assuming the other person knows what they mean. If you take medicine and it's like, let's use birth control, for example. It's got days of the week on it, starting in the middle of the week when it's not the middle of the week because you didn't pay attention to where you were supposed to be starting. A lot of times parents are contacting me because their kids are missing so much work and their kids are lying to them, which sometimes they are, but they're not always, about whether the work is actually completed or not. Our brains, most of the time, are going to assume we did something because, of course, you did, because you know you're supposed to do it. A lot of times, kids with ADHD will pull that thing out and have looked at it or know they started it in class. And so the fact that they've seen that paper or written anything on it, their brain is going to default to, yeah, I did it. And they're not double checking themselves. And the same thing will happen with completed work. Of course, I turned it in because I did the work. Why wouldn't I turn it in? I'm supposed to. I think this has gotten way more complicated now that we have so many different systems online. Kids usually at least have one system for grades and another system for work, but those systems don't always sync. And sometimes the system for work isn't going to list the paper assignments, or it's you do it in that browser and then you have to actually press submit, or it sends you somewhere else and you might have to download something and re-upload and press submit. There are so many steps along the way where something could go wrong. But if you did any of those steps, your brain's going to default to thinking, of course I did it. I'm supposed to do it. Why would I not do it? Really wanting to do something and being unable to do it, such as sitting in front of the computer and not getting any of your work done. Any kid that has ever talked to me about that has said how frustrating it is to them because why would they want to sit there forever and not get anything on paper or on the screen? And they just don't know why they can't execute it. And again, the idea of your brain telling you everything has to be done right now when it doesn't. So any of you that are managing multiple things, your job, your family, anything like that, and you've had a particularly stressful day, and then your brain is telling you all of these things that have been on your to-do list for a year now, like painting the baseboards, all needs to happen at the same time. That's the type of thing we're talking about, but on a regular basis. Okay, I've got a video here for you guys. I think we have enough time for it. So hopefully the sound will work. It was really loud when we did the test, so you might want to turn your volume down just in case it's loud for you. Perfect.
Can you replace that light bulb in the kitchen?
What does it look like I'm doing?
So that's one example from Malcolm in the Middle. And now here's another one from Modern Family.
So how do I start?
What do you think?
I don't know. Mom usually tells me what to do.
Join the club. I'm kidding. I love your mom. We are going to try a new approach this time. Now, your goal is to create a display about the life and art of Van Gogh, right?
Yeah.
Okay. Got your poster board right here. So, pretend you're telling the story of his life to someone who has never heard of him. What do you put on that board? I see the wheels spinning. The spark of
How did they
creativity.
get the lead and pencils?
Okay, let's try to stay on topic. All right, this is all you need to know right here. Apparently the pencil's in two pieces and they glue them together around the lead.
What if we put all the stuff about his life on this side and all the stuff about his paintings on this side?
Luke, buddy, that's fantastic. And the best part is you came up with that by yourself. All it took was a little bit of focus. And this thing is really loose. I'm gonna go grab a screwdriver, but you run with this. On your mark, get set, Van Gogh.
Hey, Dad, kind of looks like Uncle Mitchell. If Uncle Mitchell were insane.
Listen to these symptoms of ADHD and tell me it's not loose.
Alex.
Easily distracted by irrelevant stimuli. Often impulsively abandons one task for another.
That's where I left those.
a tendency to act without regard to consequences, often at the expense of personal safety. Having accidents
Okay, you know
more
what? I think
often-
that's enough, Alex. We've got it. Phil, honey, are you okay?
Yeah. Remember those sunglasses I couldn't find? Bingo.
All right, so those are two examples for you guys, from Malcolm in the Middle and from Modern Family. So in those, you can see the reckless abandonment of one task to another. It's like I went to go do this, and then this happened, and so then I went here. It's like starting to do one task, and you're going to put something away, then you open the pantry, and you realize how much of a mess the pantry is. So now we start organizing the pantry, but then we realize some food is bad, so we go to take the trash out. Thing after thing after thing. And then it looks like they've done nothing, but they feel like all they've done is everything. Hence why at the end of the Malcolm in the Middle episode or clip, he is very frustrated when his wife asks if he finished the task he had started originally. Another example I wanted to show you is in this slide. So a lot of times we're having kids that are doing IXL or Imagine Math or something like that, and they're designed to help with the STAR test in a lot of ways. So a lot of these questions are very similar to STAR, and they're very frustrating for people with attention problems. So if you look at these examples and you're supposed to figure out which is a graph of that function, or that equation rather, these are very similar graphs, and they're basically two different versions of them going by the same intervals, except for it's really hard to tell what's different unless you stare at it for a long time and realize the only way to figure it out is they actually switched the X and the Y axis on some of them. And so that's how you pick the right answer. But that's not measuring whether you really know which is a graph of that particular equation. It's measuring is your attention on the right things. And so you could pick out the right thing, but have it wrong solely because you missed that they intentionally mixed up where both axes were, which is very frustrating. So I had a parent tell me one time that there were so many times in K through 12 that she had to talk to teachers about her daughter and ask if she was a boy, would that behavior be as big of a deal? Because her daughter had a lot of hyperactivity. And her daughter shared with me, I feel like the clearer my head is, the more I notice how different I am when it comes to ADHD. Like if my head isn't sad or overwhelmed, etc., all I see is my differences around people near me and how I do everything different and stand out. Like we were playing Jeopardy, and my blurting out and my movement and my comments made me feel like I was the class clown or asking for attention. When in reality, I wasn't controlling anything. It was just me. I had to sit down and hold a bubble in order to get myself to react to the classroom, and then I missed details because I was so worried about keeping a bubble so I wouldn't distract too much. But we were playing as a class, so it wasn't too big of a deal for me to do something to stimulate myself in that moment. And that's a constant battle so many people are struggling with their ADHD. So that's the references of everything that we went over in this training. I wanted to ask, with a few minutes left, if anybody had any questions.
Yes, thank you, Dr. Gray, for the wonderful information. We have about 5 minutes to answer any questions. I did notice in the chat that someone asked if you had the title of your Malcolm in the Middle video. I'm not sure. It may be your references. I'm not sure. I think you deleted that.
It should be linked to the PDF where you can open it too. Hold on, it might play when I open it again, but it should tell me. When I looked it up, I literally just Googled ADHD episode Malcolm in the Middle, so I don't know the actual title. So I'm seeing if it will tell me when I open it.
I think it's very relatable for a lot of people in here.
Yeah, I would agree. Okay, if you search it by Hal fixing a light bulb, it'll come up that way too. So that's what it shows me. It doesn't give me an episode number. Sorry about
Okay.
that.
No, no worries.
Are there any other questions? I agree, though. Those videos are so relatable.
Think we were all thinking whether it was our own families
Yep.
or people we
Ourselves.
know, maybe
Yeah, yeah.
ourselves. Yes,
Coworkers, so many options.
for sure.
Hello?
Yes, I can hear you.
Yes. Okay. Dr. Gray, I have a question for you. As a parent, what are some crucial accommodations that I should be asking or requesting for my child in a school setting so that she can thrive?
How old is your child?
She's 6 years old.
Did you say 6? Sorry.
Yes.
Okay. So this is a very hard question to answer because it's not the same for every kid. I mean, there are definitely generic accommodations that everybody will say for people with ADHD,
Mhm.
whether they have the hyperactive component and need to move around or, they need to sit in a preferential area of the classroom. For me, it's more about finding things that she's actually going to use. And the same thing whether she's 6 or 16. So people with ADHD, they get all these strategies from everybody else. So take a middle schooler, if you need to remember everything, write it in your agenda, write on post-it notes. What if their brain doesn't work that way? So having the conversation with her about what she would actually use that would help her with the areas she's struggling with the most, rather than it just being an externally imposed strategy, that tends to be the most effective approach. Does that make sense?
Yes, thank you.
There's some questions in the chat. One question says, can you talk about diagnosis if PCP kind of dismisses my concerns as a parent?
So that's where it gets really tricky, especially if you need a referral from the PCP to go somewhere else, like where I am or at Cook's or anything like that, and get an evaluation. But if you don't need that referral, it would be if you can't get the input that you need there is going to talk to somebody like a psychologist or something else to get input on it, because there are lots of things that overlap. It may or may not be ADHD, and sometimes things don't sound like it, but they actually are it. And it's really the case for girls in particular with ADHD. The way the symptoms are written doesn't always match their presentation. So finding somebody who that's their specialty is probably your best route to getting some possible validation there.
Thank you. Another question was how to explain that my 12-year-old son with ADHD is gifted and talented.
Sorry, I'm trying not to laugh, like chuckle at that because it shouldn't be something that has to be explained. That sounds so overly, it's so possible to be gifted and talented in ADHD, and a lot of people think as soon as you're identified with gifted and talented, you can't be anything else. In other states, gifted and talented falls under special education too, because you learn slightly differently when you're gifted and talented. And so you shouldn't have to explain it, but I know you're going to have to. And basically, just because he's gifted and talented doesn't mean attention comes naturally to him. And part of the reason he is gifted and talented is because of his ADHD. And so taking it from that route will be helpful because it's actually his superpower when he learns how to channel it.
And then these two kind of go together. There was a question about, do you know of any books and media that are available for kids to read to help them feel less different or stigmatized? And then to follow up with that, there was also any recommendations for a book or two to understand your adult child with ADHD.
So I love finding quality books on things, but I'll be completely honest, whether we're talking about ADHD, autism, or anything else, all the books that are out there, they cover such a broad spectrum of presentation, especially when it's the individual going to read it themselves. They then are like, wait, I don't identify with this piece and this piece, and it makes it very hard for the pieces that they do identify with to resonate. And so trying to make sure based on your kid and who you need the book about, what you see in that actually relates to them as much as possible is the best thing to do. But for a lot of kids in particular, media examples are one of the best ways to do it. So that's why I love those 2 media clips that I shared, because you get to see representation in that way. And they want to say it's called the Amazing Things Project. They have done several videos on YouTube about all kinds of different things, and they're to help other kids understand what it's like with ADHD. But they work really well for kids that have ADHD to understand how their brain works too, because sometimes, I mean, we all need it. We all need to be seen, heard, and understood, and to know we're not the only ones that experience something that ends up making a world of a difference.
There were some just suggestions that other people have
Okay.
um, read about, and they were just chiming in the chat. But there was another question that said, as a diagnosed ADHD mom trying homeschooling with third grade
Oh,
ADHD
bless
child,
you.
it seems like the tension is too high. Is seeking medication too early for third grade? Is there a reverse reaction for me to take ADHD medicine if I'm still nursing?
So I would definitely encourage you to talk to your doctor about those things because I'm not a medical doctor, so I can't guarantee any of that. But I will say, even if you weren't homeschooling, I see a lot of tension come between parents and kids when parents are trying to help them with things. And it just increases as they age, when they turn into teenagers and think you know nothing and they know everything. And so anything you can do to take that off of y'all's dynamic and have an external support for that, that's a really good idea. And so I think exploring all of your options, talking to their doctor and your doctor about medication, but also other things that you can do, whether it's a tutor or something else to try to support that, because that'll just continue to put strain on the dynamic, which the more strained it is and the more tense it is, the harder it is to find effective strategies.
We had a question in the Q&A, you kind of spoke to this, I think, on your last slide on the example you gave of the girl trying to sit still in class, and would it be an issue if she were a boy? But the question was specifically, does ADHD present itself differently for girls and boys?
Yes and no. So in a lot of ways it does. When they're young, if they're not hyperactive and causing problems in class, they don't normally get attention for it. Girls, their inattention can look very different. And so, yeah, there's actually complete trainings that I do about girls. So it's a very long explanation, but yes, there can be significant differences in how they present.
Can you speak to the idea that students who struggle with ADHD can hold it together at school all day, but completely melt down and are dysregulated at home where they feel safe? How do you overcome the constant tantrums at home, and would meds help with this?
So all that kind of ties back to the idea of the capacity I was talking about. So all day that things are chipping away at their capacity. By the time they get home, there's no capacity left. Plus you're their safe place. And that's where the flip in their lid idea happens so much. And then it's also hard as a parent because when it's not seen at school, people don't understand what it's really like. Yes, there are kids that go on medication for it, and it does help some kids. It doesn't help all kids. And so making sure you get informed, or just good information to make sure you are informed will help you figure that out. But yes, that can help. So can just figuring out ways to chip away at all the things that are taking away their capacity throughout the day, such as finding effective strategies, giving them the movement breaks, finding out how to help them remember the assignments they're supposed to do. So anything we can do to chip away at that, the more likely we are to have fewer tantrums at home.
So, to follow up on that, how do you assist a child that maintains composure and is pretty perfect, according to this question, at school, but then shows the ADHD symptoms at home?
So I think, so are they wanting to know how to help them or how to make it where other people?
Yeah, good question. So, to clarify, it just says, how do you assist a child that is perfect at school but shows the ADHD at home?
I think it depends on their age. So if they were old enough to have a conversation with me about that, for example, I would find out how much effort they're exerting during the day at school, to look like their ADHD is under control completely. Because what if they're having to exert way more effort than everybody else to accomplish that? And then it basically makes the volume be turned up completely on their ADHD at home. And if it's not that much effort that they're having to exert, yet I'd find out what the difference is between the demands at home versus at school. But something tells me they're using all of their capacity at school, and that's why so many symptoms are showing at home. And so why are we using all of our capacity at school, and what can we do about that?
Awesome. Well, we really appreciate you, Dr. Gray. All of that information was very helpful. And we can't wait to implement some of those strategies that you shared with us. So thank you so much.
Thank you so much. Trying to figure out how to stop sharing for you. So
No worries. We're looking at a beautiful beach scene.
Yeah.
There we go. Awesome. Well, thank you so, so much.
Thank you.
I'm going to go ahead and introduce our next speaker, who's going to be talking with us about ADHD in the PCP's office. Dr. Lahane is a primary care pediatrician with Cook Children's in North Denton. She graduated medical school from the Texas College of Osteopathic Medicine in Fort Worth and completed her pediatric residency at the Children's Hospital of San Antonio. She has a special interest in treating mental health disorders in children and teens, including ADHD, anxiety, and depression. When she's not taking care of kiddos at work, she's busy wrangling her own 3 kids, including 1-year-old twins. I'm going to go ahead and turn it over to you, Dr. Lahane.
Hi, everybody. Thank you for joining today. I'm so excited to be able to present to you. Okay, I'm going to attempt to share here. Here we go. Okay, so again, my name is Olivia Lahane. I am one of the pediatricians with Cook Children's here in North Denton. I have a very, very special interest in ADHD, not only because I see a lot of patients with ADHD concerns. I also have a lot of experience in ADHD in my personal life and with family members. And so it's something that I'm very passionate about and something that I talk about a lot in my clinic. Throughout my presentation, you're going to see a lot of fun little anecdotal pictures. This is because, one, I think ADHD really gets a bad rep in general. There are a lot of negatives to ADHD and ADHD symptoms, but there can be a lot of positives too. And it's something that I try to focus on when I am talking to a family at a new ADHD evaluation, that there are a lot of positives to ADHD. And this picture really embodies that. With the 3 subtypes of ADHD that we see, inattentive, hyperactive, and impulsive, there are a lot of positive things that can come from those symptoms. My inattentive kids tend to be my dreamers. They tend to have really big imaginations. My hyperactive kids tend to have tons of energy I wish I could bottle for myself, because I could use a lot of that these days. And my impulsive kids are my risk takers, my kids that are fearless. You'll see in the middle here, they are all fun loving. All of my ADHD kids that I see, for the most part, are really bright, sparkly personalities. And so I try to emphasize that while there are some drawbacks to ADHD, there can be a lot of positives. And so I also try to find the humor in things. So you're going to see some fun pictures today. So today we're going to be talking about ADHD and really just the PCP's role in ADHD. So what that kind of looks like when we have a patient or a parent who is bringing concerns about their child, possibly at school or at home, and what that process looks like from beginning to end. So I wanted to start with the definition of ADHD, because this really helps us determine kind of what's going on. So in order for a child to qualify for a diagnosis of ADHD, according to the DSM-5, they have to have severe symptoms and also age inappropriate levels of symptoms. So you will see inattentiveness in kids that are under age 5, in 3 and 4-year-olds. This is not unexpected. What we want to see is, over time, that ability to pay attention, that ability to control that hyperactive movement improving. And so if we're not seeing that improvement, especially when we get to school and school age kids, that's when it's time to kind of start thinking about something going on. We want to see these symptoms present in at least 2 areas of life. So examples would be at home and at school, in after school sports and at home, even aftercare programs. So at least 2 realms, these symptoms are present. They need to be present for at least 6 months for them to qualify for a diagnosis, and they also have to be interfering with daily life. The symptoms also must not be explained by other disorders. And that is a really challenging thing, because ADHD often can be confounded with other mental health disorders. A lot of my kids with ADHD struggle with anxiety as well. I tell my families they're best friends. They love to live together and coexist together. And so teasing out which is which can be really challenging. And I think that's where really thorough neuropsychological evaluations can come in handy if there's a question. But if you're seeing straightforward ADHD, that is something that's bread and butter for PCPs and something that we deal with often. We know that ADHD is a spectrum. There is a wide range of symptoms. We were talking about even the difference between girls and boys and symptoms, and even boys in that one category can have a wide range of symptoms and there's those 3 different subtypes we talked about. So really trying to kind of figure out what are the areas of improvement for our patients, where they're struggling the most. That's going to be the most helpful thing when we're diagnosing ADHD. I wanted to talk about some of the boring things for ADHD, the pathophysiology, kind of the underlying mechanisms. While some think it's boring, I actually think it's really interesting because it really helps us understand why is this happening, how does this occur, and it really can help us drive treatment. The four I wanted to focus on today are neurochemical factors, structural changes in the brain, genetic and environmental factors. So lots of things at play here. There is not one cause for ADHD. There are a lot of things going on in our brains and in our environment that can increase the likelihood of symptoms. So to start with, neurochemical factors. We know that dopamine and norepinephrine in our brains play a big role in intention, focus, and motivation, especially in the prefrontal cortex. The prefrontal cortex is the part of our brain that is important for executive functioning, for emotional regulation, for top-down decision-making, for inattentiveness, for working memory. So if you have an imbalance of neurotransmitters, specifically dopamine and norepinephrine in the structure, you're going to see these symptoms. They have looked at studies in kids and patients with ADHD, and they have even seen through MRI studies and brain scans, actual structural changes in these patients. So I use this example down here, this picture. This is the same as this. You have ADHD, just try harder. It doesn't work like that. These patients have actual chemical imbalances. They have changes in their brain structures that can really cause these symptoms. And so it is not something you can just push through and work through. They are actually having something that is going on in their body. And I use the example, if you had a patient with a thyroid disorder, you wouldn't just tell them to work harder and push through. You would treat with hormone. And the same thing here. If you have a patient that's really struggling with ADHD symptoms, most likely they are having some imbalance of these chemicals in their brain. They may have some structural changes in their brains. And so using your tools, whether that's medication or other non-medication options, using those tools to help support those symptoms is really, really important. Genetic factors is a really important one. ADHD is the most inherited mental health disorder there is. There's about a 70 to 80% inheritance rate of ADHD. I will have a handful of patients that do not have some family member that has been affected by ADHD in my clinic. In fact, I'm often surprised that they tell me no one has this. More often than not, one family member, either diagnosed or undiagnosed, can relate to the talk that I give when we're talking about ADHD in their own child. And they'll often say, oh, wow, maybe I need to get evaluated. Maybe I need to get diagnosed. It sounds like a lot of things that I dealt with as a child and I'm still dealing with as an adult. So very, very, very high heritability rate there. And then even environmental factors can play a part in ADHD. We know exposure to tobacco, alcohol, lead, while in utero can increase likelihood of ADHD later, and also exposures to these in early childhood. So if there's someone smoking in the home, that can be something that can increase the likelihood of ADHD symptoms later. So lots of things at play here. Some common ADHD symptoms that we probably are all familiar with. We are familiar with the kiddo who is constantly fidgeting, moving, can't sit still, daydreaming, can't focus, having to be called 15 times to listen, won't put their shoes on and has to be asked 10 times to get a task completed. Lots of forgetfulness and disorganization. Impulsivity is a big one that we see. But there can be other symptoms with ADHD that are less common, but can be a sign that there's things going on. And I want to talk about those as well. We talked about emotional dysregulation in the last talk, as well as masking. And I think that's a really important thing to look for in patients. My maskers are ones where, again, just like Amanda was talking about, they chip away all day. They're using that brain power so hard to overcome those symptoms. They are working so hard to overcome that ADHD all throughout the day, that by the time they get home, they have reached their capacity and it just all falls apart. And usually because home is a familiar and comfortable environment, they just let loose. And so a lot of my families will tell me, oh my gosh, the behavior is so bad, the outbursts are so bad. And that is definitely a sign that there could be ADHD going on. Emotional dysregulation is controlled in that prefrontal cortex. So they're going to have problems with emotional dysregulation if they're having that prefrontal cortex changes that we sometimes see in ADHD patients. I get a lot of symptoms of frustration, irritability, lots of difficulty with transitions. These are really common symptoms that we see with ADHD, having those tasks, everyday tasks that are more difficult than they should be. Sibling and peer relationship issues and conflicts, that's a big one. What that will look like sometimes in the classroom is he can't keep his hands to himself. He keeps touching his peers. He's getting in their bubble. He has issues with personal space. That is an impulsivity thing, and that can be a big sign of ADHD. I've even had the constant talkers can be a big one. I had a patient a year or so ago where the littlest sibling just could not stop talking, and we call that motor mouth, where they just cannot turn it off. And it was causing such issues with sibling relationships that we decided to go ahead and treat because it was just making life miserable at home, and it made a huge difference for that family. One symptom I wanted to talk about with ADHD, and one that can actually be a positive, is that hyperfocus. Hyperfocus can also really muddy the picture for a parent because they'll come in and they'll say, they can't focus on anything, but when it comes to video games, when it comes to TV, you can't tear them away from it. Why can they focus on this, but they can't focus on the things they should be focusing on? Well, it's because in an ADHD brain, their brain prioritizes the things that are interesting to them. And hyperfocus is a hallmark of ADHD. And it is something that people without ADHD do not get to experience. And so I tell my families, hey, hyperfocus actually can be a really beautiful thing, because later in life, when that child finds what they want to do and what they're passionate about, hopefully they'll have no problem paying attention to it and learning about it and being successful at it, because they have the ability to hyperfocus on things that they really enjoy. This is oftentimes why you will see a child in school do really well in a certain subject, even if they have ADHD, because their brain really prioritizes that subject and finds it interesting. But then subjects that maybe aren't as interesting to that child are going to be a lot more difficult. And reading comprehension tends to be the biggest one that I see. Reading, you really have to have a strong attention factor there to comprehend what you're reading, to retain what you're reading. And so I often will hear patients tell me, we struggle in reading, we struggle in language arts. That's our biggest weakness point. So that's something I will often see. So what happens next? So we're having a patient with some of these symptoms, probably not all of them, and not all ADHD patients exhibit all of those symptoms. But what happens when we're seeing some things and it's starting to interfere with school or life? So one, I take into account the age. Age is really, really important because, again, if you have a child who's 3 or 4, we need a little time for that prefrontal cortex to develop. We need a little time for the brain to develop. So I often will wait and kind of watch. Now, obviously, if we're having major behavioral issues where, we're getting kicked out of daycare or something like that, then we want to intervene earlier. But if it's not interfering with their life and it's just something parents are noticing, I will keep a close eye. I usually recommend, if we're having issues, starting to screen halfway through kindergarten. I think getting your feet wet in school at the beginning of the year, sometimes it can be a little bit of a transition. But if we're still having a lot of issues halfway through that first part of the year, then I usually will say, okay, let's go ahead and start the screening process. Let's get things going. The earliest I tend to evaluate is around 5 or 6, but again, I make special, exceptions for patients that are really struggling. And sometimes that even means referring them for a more in-depth evaluation, especially if it's a younger kid who's having a lot of issues, because there could be more things at play there. So what does screening look like? What does diagnosis look like? So in my clinic, how we start. So if we have a patient that calls in or brings up issues at a well check, I usually will provide what's called Vanderbilt forms. So to start with, ADHD, by the way, is a clinical diagnosis. It is based on history. There are no labs, there are no imaging that we can get to confirm a diagnosis. It really is based off of what the parents and the patients are telling me. We do use screener tools to help aid in diagnosis, but they're not intended to diagnose. They're intended just to give you more information about symptoms, about severity, even about performance. So Vanderbilts tend to be our first line for screeners for PCPs. There are a lot of other screeners that you can use, and I listed them here: the Connor CPT-3, there's the ADHD rating scale, the SNAP-4. General pediatricians tend not to use those. Those tend to be reserved for therapists and licensed psychologists to use to kind of get a better idea of the mental health picture going on. Vanderbilts tend to be kind of in our realm, and that's what we start with. I love Vanderbilt's because it gives you a lot of information. So what that looks like, and I'm going to put it, I'll go ahead and scroll over to Vanderbilt's here. So there are two forms that I usually give out. One is going to be a parent informant form, and the other is going to be a teacher informant form. So we're getting information from the parent and the teacher. So two realms, two areas of problems. The first set of questions here, so 1 through 9, deals with inattentive symptoms. The next set, 10 through 18, deals with hyperactivity, impulsivity. The next set of questions, 19 through, I believe, 26, is oppositional defiant disorder. So this is looking at kids who deal with those oppositional symptoms, kind of defiant symptoms. 26 through 38, 9, sorry about that. I had these written down and they're gone. Those deal with conduct disorder. Conduct disorder is serious. We are going to therapy. We are getting a full clinical diagnosis if I'm getting anything screen positive on there. And then the last set deals with anxiety and depression. The way you score the Vanderbilt, so when you're going through this form, you're rating your child from 0, 1, 2, and 3. 0 meaning they never have symptoms, 3 meaning they have these very often. To qualify for a diagnosis of ADHD, or to help at least guide our diagnosis, a positive screen would be 6, 2 to 3. So you have to have a score of 2 or 3 in 6 out of the 9 questions, in questions 1 through 18. Again, these first 9 are inattentive type. The second 9 are hyperactive impulsive type. If you have a patient with combined ADHD, they will have a score of, sorry, this is hard to say, a score of 2 to 3 in 6 out of the 9 in both of these sections to get a combined ADHD diagnosis. So I will have patients that have only inattentive type, and they will be high scores here. I will have some patients that will have high scores in just hyperactivity, impulsivity, and I will have patients that have high scores in both. What we don't want to see is lots of high scores down in these lower ones. Oh, sorry about that. Because that means something else is going on and we need to evaluate a little bit further. Same thing with these anxiety, depression symptoms. If we're seeing lots of high scores over here, we really should be getting a full neuropsychological evaluation to make sure we're not missing something. We also, you can see, have an area for performance. So the teachers can rate them on performance with not only like reading, writing, mathematics, but also with relationship with parents and siblings. So really important information here. So once we have the Vanderbilts, once we kind of go through the history and we are pretty certain a patient has ADHD, we move on to management. So how do we manage ADHD? What do we do to help this patient, support this patient, this child in school? There are a lot of ways to treat ADHD that are not medication. I always talk about medication during these visits, not to make a parent have to decide or a patient have to decide, but just to give them information about it and so that they can make the best decision for them and their family. Non-medication options, super important part of management of ADHD. And I would say almost as equally as effective as medication when used in the right way. I am not going to go into detail about non-medication options today because I know our next speaker is going to be talking about that a little bit more in depth. But I did want to touch on it because it is a super important part of ADHD and managing ADHD. The number one thing I do for any patient that comes into my clinic who gets a diagnosis of ADHD, I am writing them a letter for school that day to request a 504 plan for accommodations. The state of Texas is required by law in all public schools to provide accommodations for patients that have a disability. ADHD is considered a disability in the state of Texas. And so if a patient is dealing with ADHD, we really want to make sure they have some good accommodations in place through school to help support their learning. Common accommodations that my students request and help them look like things like extended time on tests, extended time on assignments, going to a quiet room to take a test, preferential seating in class, allowing physical movement on breaks, having a fidget spinner. There are a lot of little tiny things that the school can provide that student to kind of help support their learning, support their symptoms throughout the day. You'd be surprised at how many different accommodations there are. There's lists out there, tons of lists on the internet you can find if that's something you want to look into. But I always recommend for any patient, even if we don't start medicine, definitely request accommodations through school because this will help support their learning. Lifestyle changes is a big part about a non-medication option part to treating ADHD. My big three, I have a big handout that I give in these visits, and my big three are sleep, diet, and exercise. We want to try to maximize these three components in our lives to kind of not only treat ADHD, but also just to live a healthy life. For sleep, so important. We do our best learning when we're asleep. Everything that our brain learns in our short-term memory during the day, it moves to long-term memory at night when we're asleep. It's a process called consolidation. And so I always stress the importance of sleep and regular sleep to my families. We want to try to aim for at least 9 to 10 hours a night for a child in school, consistent sleep. Diet is a really important part of ADHD. And this is one of the most challenging parts of ADHD. And I don't know if any of you have kids or if any of you have picky kids, but all three of my kids are very, very picky eaters. So diet can be a really, really challenging part, but something that I think we make little changes over time. I don't ever expect a family to just completely overhaul their life, right? And I also don't expect a family to just cut out all the yummy good things that the child enjoys eating. Everything in moderation. If we can try to incorporate fruits, veggies, lean proteins into meals, that's going to be a great starting point. Protein is a really, really important part about treating ADHD. I really recommend for my families that are struggling with ADHD symptoms, especially like behavior stuff in the morning, incorporate protein in your meals. Protein in our body, when we have protein, it keeps our blood sugar nice and stable throughout the day. It doesn't allow those major blood sugar fluctuations that you'll see in kids that eat like high sugary meals, high carb meals like cereal, those kind of things. So we want to try to incorporate protein throughout the day to kind of help keep those blood sugar fluctuations minimal. So that way we're not seeing crazy changes in symptoms throughout the day. I get a lot of questions about vitamins and supplements from patients. And what I tell my families is there is absolutely a role for vitamins and supplements. There is no problem in taking vitamins and supplements. However, if a patient needs medication, these will not take them far enough. It is not going to get you far enough to where you need to be able to be successful in school if you're having ADHD symptoms that are affecting your performance. However, we absolutely always give it a try if that's what the family wants to do. The biggest one I recommend starting if we are not interested in medication, but we're really, really wanting to try to supplement, it would be a omega-3. There's a gummy form of omega-3s from a company called Nordic Naturals. That's a good omega-3. We know in studies that omega-3s can significantly help ADHD symptoms. A few others that I recommend. So one, if you have a picky eater, you're worried about the amount of nutrients and vitamins they're getting, a multivitamin is fine to start. We know there's a big link between the gut and the mind. And so starting a probiotic, we have seen in recent studies, can help aid ADHD symptoms. And then finally, vitamin D is a big one we see with ADHD. And so if I have a child that's really not getting outside a lot with sports, I will start vitamin D to help aid ADHD symptoms as well. Therapy also plays a huge role in ADHD. I know we'll talk about that a little bit later, but I do have patients that pursue therapy just to help with coping skills with ADHD symptoms. And I think that's something that can carry on with them throughout their lives. It's something that can be really, really helpful. Number one question I get during these visits is, when is the right time to start medication? How do we know it's time? And what I tell my families is, if your child is starting to lose confidence in school, is starting to complain about having to go to school, we're seeing grades drop, we're seeing performance affected, that is the time to intervene. The last thing we want is for a child to lose their love for learning, to get so frustrated that their confidence levels just tank. We want to intervene before we lose confidence. That is how we are going to continue to help build their success in school. So if we're starting to see performance slide and confidence in school slide, that is the time to intervene and think about treating with medication. The majority of my talk today is going to be about pharmacological therapy, about medications, and so we'll jump into that right now. Two big categories of medication that we use to treat ADHD. We have our stimulants and our non-stimulants. Those are our two big umbrellas we're going to talk about today. So stimulants are the big one. These are the ones that everybody's familiar with. These are examples are Adderall, Focalin, Concerta, Vyvanse. These are by far the most commonly prescribed. These are the mainstay of treatment. These are first line for children, adolescents, and adults for ADHD. The big reason these are the mainstay of treatment is there's twofold. One, they are extremely effective. There is a 70 to 90% response rate and improvement in ADHD symptoms after starting a stimulant. The other reason we also recommend starting with these is their rapid onset of action. These medications work the day you take them. They have a really, really quick onset. And so you're going to notice an immediate change in behavior if this is the right medication for your child. It is one of the only medications that we have out there that is like almost instant gratification. The day you take it, you're going to notice an improvement in symptoms. On that note, if you have a child who starts stimulant medication and you are seeing something that you don't like, you're going to know right away. That's another big positive is if there's something going on and you're seeing, okay, I don't like how they're acting, I don't like how they're looking on this, you can stop it because you're going to see it right when you start them. The pathophysiology behind stimulants. So all of these stimulants, the Adderall, Focalin, Concerta, they all have different mechanisms of action. They're all in different classes, but they all fall under the stimulant category because all of them increase the availability of dopamine and norepinephrine, which is what we talked about earlier. Those are the neurotransmitters that we're worried about. These all increase the availability of dopamine and norepinephrine in that prefrontal cortex. This is why they work and they're so effective. One of the downsides to stimulants, they are controlled substances. Because they increase the availability of dopamine in that prefrontal cortex, that is why there is a higher abuse potential. Because you are having an effect on dopamine. We know dopamine in the brain can lead to addictive traits. And so that is why these medications are a Schedule II. That just means that there is a medical reason we use them, but there is a high risk of abuse and addiction because of that dopamine release from the medications. One really important thing to keep in mind with this, because this is what scares a lot of families. Studies have shown that if a patient needs ADHD medication, starting a medication early, lots of studies have shown this, starting an ADHD medication early, a stimulant medication early in a childhood, there is no increased risk of misuse or substance abuse in adulthood using this medication, compared to starting the medication in adolescents or adults. I think that's a really important piece to keep in mind because this scares a lot of families. Is my child going to be addicted to this medicine, or am I worried about substance abuse? If you're starting this early and they truly need the medicine, the studies have shown us that there is no increased risk of misuse later compared to if you start this medicine in adults later on in life. One of the positives of stimulants is that there's lots of different formulations. We will use the long-acting often in patients because there is a lower likelihood of misuse in the longer-acting formulation. That is because they're not so rapid onset, rapid offset. That because that's short-acting, it's a quick dopamine release and quick off. You almost need more, so that increases the likelihood of misusing. If you're just doing a once a day where it's a prolonged, extended release, you're not going to have that same dopamine hit you're getting from the short acting. So for our pediatrician guidelines, we always start in short acting in kids under age 6, twice daily dosing, but I will quickly move to the long acting once they get that 6 to 7 age range to make sure that we're on a once daily dosing. Families also tend to want to only do once daily dosing as well. It's a lot easier on the schedule. They don't have to go to the nurse. So for those reasons, the long acting tends to be a much more desired formulation. Another big positive of the stimulant medications is because there's such rapid onset and rapid offset, you can kind of pick and choose when you take the medicines. I have patients that use stimulants on test days only. They really get distracted. They really have attention problems during tests, and they really need that focus there. But during school, they don't have as big of an issue. This tends to be my older kids. I have kids that just need it for school days, and on weekends, we give them med breaks. We give them holidays. Same thing with summer break. And that is one beautiful thing about stimulants. And I would say a majority of my patients really don't need medicine on the weekends. There are a handful that do, but a majority, I would say, really are just needing it for school just to kind of make sure we have that focus there when we're learning. And so that's one nice thing about these medicines is that you can kind of pick and choose the days you use them and take breaks if you need to because of that rapid onset and offset of action. Non-stimulants. So these medications we do not tend to start with unless I am I think a lot of things that go into choosing medication. A lot of things go through my head when I'm choosing medication for patients. The age of the patient, the symptoms, the time of day they're experiencing symptoms, the patient's insurance, if there's a substance abuse history in the family, if the patient has concurrent medical issues such as tics or insomnia. There are a lot of different things that go into play when I'm choosing medication for a patient. There are a handful of patients that I have started patients on non-stimulants on. But as a whole, we tend to start with stimulants because, again, those are first line. Those are going to be the most effective, and those tend to work really, really well right away. However, if I have a patient that either fails stimulants, and by the way, if you fail a stimulant, I'm going to go back again really quickly. If you fail a stimulant, studies have shown us that half of kids who fail a stimulant will do better on a different class. So what we recommend is if, say, we start with Adderall and it's not a good fit, we're having side effects, we do switch to a different stimulant to see if it's a better fit. Same thing with side effects or with effectiveness. If you're not getting effectiveness or if you're having side effects on one of these classes, about half of kids will do better on a different one. So it is worth trying a few different before we say, okay, stimulants are not for you. Let's move on. However, if I have a child, and there's one off the top of my head I can think of, he's a really, really smart kid. He's doing really well in school, performing well, probably has ADHD at school, but his intelligence is taking him far enough. He's able to math throughout the day. When he got to baseball practice in the evening time, it fell apart. He fell apart. Huge outburst, totally unlike him. Couldn't pay attention, really having trouble focusing. So for him, it was not ideal to start a stimulant when evening time is his biggest symptom. So after discussion with that family, we decided, let's go ahead and try a non-stimulant every day. Let's see if something that is a non-stimulant that you can use for 24 hours is going to work a little bit better. And that's how these non-stimulants work. So there's two categories that we're going to talk about today. The SNRIs, which stands for selective norepinephrine reuptake inhibitors, and the alpha-2 adrenergic agonists. The SNRIs are like Strattera and Qelbree. The alpha-2s, Intuniv and Clonidine or Capve. These medications we tend to recommend taking at night. These medications are medications that are a much slower onset of action. It takes a few weeks for these medications to really show an effect with ADHD symptoms, which is why they're not ideal, because it can take some time to really see a benefit. These medications at their heart are actually blood pressure medications. So a lot of these medications are used to treat blood pressure, but we know because of their mechanism of action, they can have a huge impact on ADHD symptoms. And these tend to deal with more of increasing availability of norepinephrine. So these will not have that increase of dopamine that the stimulants have, which is why these are not controlled substances. They're not the ones that are going to have a potential for abuse because they are not dealing with dopamine. They are purely dealing with norepinephrine in that prefrontal cortex. SNRIs, that selective norepinephrine reuptake inhibitor, they stop the reuptake of norepinephrine. So they stop the channels from sucking up the norepinephrine and let it linger around longer in the brain. That's how those work. Same thing with the alpha-2s. They increase the bioavailability of norepinephrine. So you're not going to get that abuse potential with the non-stimulants, which can be ideal for a family who, say, has substance abuse disorders, has a family member who abused stimulants. This would be an ideal medicine to try for that family. But again, for a family where a patient is having symptoms at night, mostly in the evening is when we're really struggling, this can be a really good medicine because these medicines stay in the system all the time. They're always working. I even have patients that really struggle with behavior throughout and then also need a little stimulant in the morning to help boost those symptoms. So these medicines can be taken in conjunction with stimulants to help with ADHD symptoms. Non-stimulants do tend to be less effective than stimulants, which is what makes them not as great of treatment options. However, there's absolutely a place for non-stimulants. I think they are wonderful medications. And the really nice thing about the non-stimulants is that you're not going to have the same side effects that you're having with the stimulants. And we're going to talk about side effects in a little bit. But non-stimulants tend to be much more tolerated if you are having side effects. So a really good option for a kid who's struggling with stimulants from a side effect standpoint. So what happens after we start medication? So we choose a medication, whether it's a stimulant or a non-stimulant. What comes next? Well, first, I want to mention something I hadn't talked about yet. Something I stress to my families, because I do get a lot of hesitancy from families about starting medication. It is something that I deal with commonly. And a lot of times it's because a family member was treated for ADHD when they were younger and had a really bad outcome, had a really bad experience, and doesn't want that for their child, which is absolutely understandable. I try to stress to my families that there's a lot of new medications out there now that there weren't available back when we were treating. There's a lot of different dosages out there and formulations out there now that weren't available back when we were treating. Back in those days when we were in school, when we were in elementary school, we didn't even know what to look for. We didn't know that daydreaming was a symptom of ADHD. And so I think there's a lot better screening process now. That's why we see ADHD so much more prevalently. I truly believe it has been there for a long time. Now, we can talk about screen time and social media and how that can increase the impact. And I definitely think that has a part. But I do truly believe a lot of us were undiagnosed as children, and we just develop coping skills over time to deal with it. And then we, continue to have ADHD symptoms on and off throughout our lives. But now we have better screening tools to know what to look for. And I try to stress to my families that the treatment options as well are much better than they were when we were kids. So to kind of keep an open mind going into medications. My ideal medication for a child is one where the child feels no different. They have the same personality. They're still silly. They're still goofy. They can still have fun with their friends. But when it comes time to focus, to do a task, to pay attention in class, they can do it no problem. That brain can turn it on, no problem. That is what we're looking for. And 9 times out of 10 at those follow-up visits, my kids will tell me, oh, I don't feel anything. I don't feel different. And my parents like, oh no, it's way better. The teachers aren't calling us anymore. Teachers have told us things are so much better. We're noticing an improvement. That is the medicine we want. My child doesn't feel different, but I know that things are better and they're not having much issue with ADHD. Sometimes the kid will also tell me, oh yeah, I feel better. I feel like it's easier to concentrate. But usually they're telling, I don't feel any different. And that's what we want. We don't want to be dealing with side effects. So for that reason, we do very close follow-up after starting these medications, just to make sure that we are not running into side effects, making sure the dose is accurate, making sure that we are looking at vital signs, looking at weight, looking at growth. So I usually see my patients back within 4 weeks after starting a medication in clinic, just to make sure we're doing okay. I encourage my families before that visit, if they're running into any issues, reach out to me over the portal, call my clinic. I don't want you to wait. You let me know if you're seeing things that you don't like so we can talk about it and make a change if we need to. Once I see them for that month follow-up, if things are going great, I tend to see my kids about every 3 to 6 months, just to kind of check in throughout the year, make sure we're doing okay, make sure the dose is appropriate, if it's still effective. These medications are weight-based dosing. And so as a child gets older, gets bigger, sometimes they will need some dose adjustments just based on their weight and their growth. We also want to make sure they're not having side effects too, not making sure they're growing fine. We're not seeing weight and height affected. We're not having side effects that are worse than the ADHD symptoms themselves. And so those are things that I look for on a regular basis throughout the year. And then I always encourage regular updates from my families. I'm always happy to get updates. I love positive updates. That just makes my day to hear a patient's doing great. So I always tell my families, write me in, tell me how things are going. I'm always happy to hear and troubleshoot with you. A lot of the dose adjustments we can do over the computer, over the phone. I don't make a family come in every time we need to make a dose adjustment. But if we're having major issues or we're having any concerns, I do have them come in so we can talk about it a little more in depth. Okay, so I wanted to touch quickly on safety concerns with ADHD medications. We talked about this a little bit already, but wanted to get a little bit more in depth in which side effects we're looking for, because that can be a really big part about ADHD. It's a really common question I get. So what would I expect starting a stimulant side effect wise? Honestly, I would not expect much. The most common thing I see, especially because we're starting at low doses, and by the way, we start at a low dose for every patient, no matter if I have a kid who's crawling on my ceiling and I think is going to need a higher dose, I start low and we go slow. That way we're not overshooting it, because as you go up on the stimulant medications, and by the way, this slide is just dealing with stimulants. As you go up on the stimulant dose, the likelihood of side effects increases. So you're not going to tend to see a lot of side effects at the lower doses. However, there are a handful of patients that will be sensitive to these, and those are the ones I'm looking for. What I commonly hear starting out low, the biggest one is appetite. I'm not as hungry as I normally am. Usually lunch is the most effective meal because that is when those extended release stimulants peak. And so I typically tell my families, take this medicine after breakfast, get a good breakfast in our tummy, preferably with some protein in there. And then if a kid is often one that gets their lunch at school, I'll tell my families, okay, pack snacks, pack a lunch, have a visual reminder that there's lunch there to eat so they can remember to eat. Sometimes the medication is working so well, we can forget to eat. And it also just doesn't make you as hungry. So having that visual reminder can be really helpful in making sure we're not missing meals. Usually once the medicine has worn off, which by the way, the stimulant medication, the duration is about 8 hours, so about the length of a school day. Once that medication wears off, they usually will have a nice normal snack when they get home from school, and then dinner should be unaffected. So for those reasons, I tend not to see growth be a big issue. However, if I do have a child who is already failure to thrive, is already having struggles with weight gain, we really watch this closely. And so that can actually be a reason why we start with non-stimulants instead of stimulants if we're worried about growth. Some other common side effects or uncommon side effects that we see, sleep. The nice thing about these medicines is that most of the time these medicines are worn off by the time it's time to go to sleep. So I tend not to see that one be a huge issue. Personality changes are the biggest one that my families worry about. And again, an ideal medicine is one where my kids should feel the same. They shouldn't feel off. They shouldn't feel weird. They shouldn't feel zombie-like. If they are feeling that, especially at the low doses, we are on the wrong medicine and we need to make a change. So I watch personality changes really, really closely. I encourage my patients. I try to give, advocate for yourself. Talk to mom and dad. Tell them how you're feeling. Make sure you're open conversation, open communication at home so we can kind of keep track of these symptoms to make sure that's not what we're experiencing. Other ones we can see, very rarely we can have hallucination, psychosis, even suicidal ideations. This is not common. This is very, very rare. I've probably had 1 or 2 out of the hundreds that I've treated deal with these. If that happens, you're going to know quickly. We're going to stop the medicine right away. I always tell my families, if you notice anything concerning you, call me right away and we make a change. I would not expect these to be side effects, but it's important to know what to look for in case that's something that a child experiences after starting these medications. Misuse is another safety concern. What I would say is, and again, speaking to those studies that we have seen where starting stimulants in early childhood does not increase the risk of misuse. Misuse tends not to be something that I deal with in my practice, in my patient population. I have not seen, I can't even think of one off the top of my head where I've had a misuse. I've had one where divorced parents, one was getting it from one doctor, one was getting it from me. And that was the only off the top of my head example that I can think of. So what's nice is in at least the pediatric population, you're not going to be seeing a lot of misuse. However, it's something that we absolutely always have to keep in mind. And again, we talked about how there's a much less likelihood of abuse for stimulants when they are prescribed and monitored carefully, as well as starting at a younger age. There actually is an increased risk of substance use, a 3 to 4 times increased risk in substance use in patients with undiagnosed ADHD who are not treated with stimulants. So what that looks like is if a patient has ADHD and they're undiagnosed and they're getting through life and they're just kind of struggling getting by, that patient is 3 to 4 times more likely to use a medication or a substance to help improve their symptoms, to self-medicate, than if we were to just go ahead and medicate them with stimulants and monitor and watch them closely. So that actually rings for another reason why it's really important to intervene and consider medications if you have a patient that is struggling with ADHD symptoms. We talked about how long-acting stimulants, because of their longer duration, have a lower potential for abuse, and then the non-stimulants as well, because you're not having that dopamine release. You're not going to have the abuse potential there. That's another good reason to think about those medicines if you're worried about that. Parents play a big role in misuse. You'd be surprised at how many parents just give their kid the medicine and let them take it. mom and dad, they have ADHD. They're going to have a hard time remembering to take their medicines. So I really try to involve my parent, make sure that they are staying on top of the medicines. These medicines are they're scheduled for a reason. They're controlled substances. So it's important for the parent to play an active role in their child taking these medications. There's also a program out there for physicians called the PDMP. This is the Prescription Drug Monitoring Program. This is a program that's statewide, and all states have this program where it tells you all of the controlled substances that have been prescribed for that patient up until I think it's the last 6 months. And so that is a way to kind of see, okay, are we getting medications elsewhere? Do we have anything else going on? Are we filling it too often? This is kind of just a good way to make sure that we're using these safely and correctly. So lots of good safeguards in there to help with misuse. So just some final thoughts. One thing I really stress to my families, and a question I get a lot is, how long should we expect for my child to experience these symptoms? Is this going to go on the rest of their lives? We know from the studies about half of kids will have persistent symptoms into adulthood. That means that half of kids will be able to develop good coping skills, good strategies to help overcome symptoms where they don't need medication. Just the brain developing, maturing, that prefrontal cortex over time helps with ADHD symptoms not being as big of a deal as they get older. So we know from studies that those symptoms do appear to improve over time, regardless of what treatment we use. I think it's important to note that significant changes can be made to behavior and ADHD symptoms even without medications. And we're going to talk about that, I think, in the next talk about a lot of non-medication options to treat ADHD. But you do not have to have medications to treat ADHD. It is not a requirement. However, these medications are very safe, very effective, and in the right patient, they can make such a huge difference. And that's why I ended on this little comment. With the proper medication, they live happily ever after. If you have a pediatrician that is monitoring your medicine closely and making sure that you're not having side effects, it's working well, these medications can really make a huge difference in the lives of these patients. And so something to consider when you have a patient that's struggling with ADHD symptoms. I think that's the end of my talk.
Thank you so much, Dr.
You're
Lehane. That was
welcome.
so informative. We do have some time for some questions. I will say that there were some people that were in the chat typing some questions, and maybe you have already answered them at this point because it was part of your...
I'm not going to lie. I did not even look at the chat because I knew it was going to totally distract me from what I was talking about. So I figured I'd go scroll back up
Yeah, and I can help with that too. So there was a question about some non-medication options to help support young children. I know when you were talking about those options like accommodations at school and lifestyle changes, looking at exercise and sleep habits and vitamin supplements therapy, all the things. But the second part of the question was, if you have a student that's masking during the school day and then having the tantrums when they get home, how does that affect the diagnosis since it needs to be present in two areas of their life?
That's a really good question. And that can make ADHD challenging. And I tend to see this more in girls where they're at school, they're like perfect angels, teacher's pet. They are putting it on all day. They want to be, and it's my perfectionism girls. You can be a perfectionist and still have ADHD. So I think while we do have a criteria to meet for ADHD, again, clinical history is the most important thing here. And if I have a patient, even if I'm not seeing it in two realms, if I'm hearing enough from my family, it's for me to say, okay, I think this is what's going on. I usually will give a diagnosis, even if it's not present in both those realms, because I certainly would not want that patient to suffer just because they're not having meltdowns at school. And I think that it's worth talking about and treating. And if that means non-medication options, that's great. I still will request accommodations. But if that means medication, then that's a conversation we'll have as well.
Awesome. The next question was, how is this affected by overload of after-school activities? Is a reduced or low-key schedule after school beneficial?
Twofold. One, physical activity can be so helpful for ADHD. So soccer is the one sport that I use. That running for a kid who has hyperactive type ADHD, man, that can make a huge difference. But on the same playing field there. If you're having a lot of issues with concentration, soccer, baseball, those things can be very, very difficult. So I think it's individual. And I think treating ADHD in general is such an individual thing. Everyone's different. Everyone has different experiences and side effects and outcomes from these medications, from treatment options. So I think it depends on the child. When I recommend reducing a schedule is if I'm seeing a lot of anxiety. If I'm seeing a lot of anxiety, if I'm seeing a lot of overwhelming panic, life is falling apart, I usually am talking to the family about, okay, we really need to make sure we are picking things that is bringing joy to our lives, that we're not feeling overwhelmed. Is there somewhere in our schedule where we can make a difference? So I think it's a very tricky line to cross, because you want your kid involved and you want them to be doing physically active things, but you don't want to overload them with school. One thing I do stress to my families is school is number one priority. Sports comes second, school is first. So if it's affecting performance, late night practices, that's something we need to talk about and kind of see if we can make some changes too.
Yeah. Any ideas on how you can overcome the challenge with reading focus, like how you can address that with accommodations that don't include medication?
It's so hard. And my 5-year-old, I am certain will be going down this route in the next year, because I'm already starting to see signs just as a pediatrician. It's really, really difficult. Reading is a really challenging thing for someone who cannot focus. I think lots of practice, making it fun, because children who have a hard time with reading with letters, if you're sitting down and making them look at letters, it's like torture to them. So incorporating it into games, there's lots of games and memory games out there. One of my non-medication option treatments on my little handout that I give is practicing with memory games, recall games, games that incorporate letters. Make it fun for them. That's going to be a really, really impactful way in a child to make it see improvements. And so there are lots of little things out there. There's even little letter push things you can do. There are letter games, letter bingo. There are lots of different things that I've already actually started looking for my son, because he struggles with letters and he gets frustrated and irritable and doesn't want to do it. So I think making it fun is a really, really good way to kind of help encourage that reading.
You kind of touched on this one, but do you know of any concerning long-term side effects from ADHD medications?
Good question. In a patient who is monitored closely, who is watched by their doctor closely, I would not expect any major long-term side effects, especially because we are watching growth so closely. We're watching vital signs so closely. I would not expect a patient using these long-term to have any kind of side effects. Now, if for some reason a doctor has prescribed them and didn't follow up and they just kept renewing, then yeah, of course, if we're not watching closely, that is something that I really stress to my families is, hey, we are watching you closely. I really want a lot of communication, open dialogue here to make sure that we're not dealing with side effects. But no, I am not concerned about long-term side effects in our kids with stimulants, as long as we are being monitored closely and making sure we have just open communication, open dialogue about symptoms and side effects.
Well, someone asked if anyone would be addressing the correlation. So maybe you have some knowledge on this, but between sleep apnea and ADHD?
That's a really, really good one. And I'm not exactly sure of the correlation, other than I know that sleep apnea can absolutely lead to ADHD symptoms. And the reason is, we talked about before, sleep is so important, and consistent sleep is so important for ADHD. And if you're not getting good, consistent, restful sleep, it will absolutely increase your symptoms. So while it may not cause ADHD, if there is existing ADHD, it will absolutely worsen the symptoms. And sometimes just the sleep apnea alone can really bring on the symptoms. And so if I have a patient that is snoring, and that's actually something we do talk about during my visits. Okay, are we seeing snoring? What kind of sleep issues are we dealing with? Is it hard to fall asleep at night? Those are all things that I'm asking about and looking for. And if we're having major sleep issues, one, I will think about maybe even treating with a non-stimulant, because those tend to be medicines that actually do help aid in sleep and falling asleep. And two, if I'm really concerned, I am getting them over to either sleep medicine or ENT, so we can address sleep apnea and make sure that piece of it is getting addressed, because that can absolutely affect their symptoms and the improvement in symptoms by addressing that underlying issue.
Awesome. Someone asked about when we were talking about the healthy foods and making sure kiddos, even picky eaters, are somehow getting our proteins and veggies and all the things. Should we still limit those high sugar snacks? So for kids that are already good about eating their healthy foods,
Yeah.
any suggestions on that?
Having kids has changed my perspective over time on this. I used to be very like regimented and like no high sugar, no it's, you can't deprive a kid of sugary things. It makes life fun. It makes life exciting. Limiting, yes, everything in moderation. Candy once in a while is not going to hurt your child. I tell my families, do not get crazy over this. Now, I do have some families that swear by like eliminating dyes. It made a huge difference for their family. And I think there's nothing wrong in giving that a try and seeing, but I do not expect all my families to eliminate dyes completely from their diet. That would be very hard to do. And we know that if we're eating these things in moderation, it is not affecting our bodies in a long-term way. And so do we limit high sugar things? Yes. Do I allow them? Absolutely. Life would not be worth living if we couldn't have some candy and some cake once in a while. But if we're having it every day, that's where I kind of, hey, let's make some changes. Let's see how we can, can we do like a protein cake? And like, there's healthier options there. If a child really, really likes it. One hill I will die on is sugary sodas. Zero sugary sodas. Never, ever, ever. There is no nutritional content there. It is all sugar. They can be addictive because they do have caffeine in them. So that is one thing I do say. Because the question I get actually quite a bit is, can we use caffeine drinks instead of stimulants? A lot of my kids, when they graduate and go to college, will come off the stimulants and move to caffeine. Do a tea or a coffee, something not high in sugar. That way you're not spiking that blood sugar throughout the day, those blood sugar spikes we talked about. Caffeine is absolutely fine to use, and it works very similar to the stimulants in a lesser way. But if we want to avoid the sugar content in those drinks, and that sugary drinks is the one thing I say, if you can stop those completely, switch to water, milk, that is what we want to try to aim for.
Awesome. There were some questions about the Vanderbilt forms that you're using. So one question was, do you need parent consent to complete that form in the public school setting?
That's a good question. I have never had a parent not like a school start doing a Vanderbilt without the parent knowing about it. I can't think of one time. And usually this is parent driven. And schools actually are not allowed to call our clinic and say we're having issues. That's a HIPAA violation. So I believe, yes, the school would need consent. And oftentimes if the school is seeing ADHD symptoms, they are reaching out to the parent. They are recommending testing. They're doing testing on their own, like dyslexia testing. There's learning disability testing they'll do through school, but they are usually communicating with the patient, hopefully, and not just reaching out to me. So yes, I would think that they need parental consent, and I need the parent form to be able to move forward with a diagnosis. So I have to have a parent weigh in. I can't just go off the teacher. Yes, I think that the parent would have to consent to that.
And on that same note, if you have a family who chooses to homeschool, and so they are the parent and the teacher, and they may not have like a true second contributor, how do you handle those situations?
I have my mom look at it from mom perspective, and then I have her fill it out from teacher perspective. That's how I deal with that.
Perfect. I think we have time for a few more. We have quite a few things in here. How about heart issues with long-term use?
Same kind of thing. I think if these medications are monitored closely, we are watching them closely. I am not concerned about long-term issues, heart issues with these medications. It's not something that I'm concerned about from my perspective because these medications are monitored so closely. It's not something that we see or deal with.
And then suggestions for, I know you mentioned that sometimes medication can decrease appetite. So what if you have a kid that's already having a hard time eating? They get distracted, they take a long time with eating, even with consistent reminders, and even when they're hungry. Any suggestions for those kiddos?
It's tough. And I'm reading the next part of the question.
Oh,
If you know they do not eat at school, even when lunch is packed, how can we ensure they eat? The biggest thing is, if I have a child who we're worried about their growth, I am definitely having them come in more frequently, and not even for visits, just for a nurse visit. Come, let's weigh you. Let's weigh you monthly. Let's make sure that we're meeting our requirement. But to answer that, if we are truly struggling with eating already and it's affecting our growth, we should not be taking stimulants. A non-stimulant would be a really good option for that patient because it's not going to come with the same side effects as stimulants. You're not going to have those appetite issues with non-stimulants. So I think in that child who really struggles with eating, if we are seeing growth changes, we should be considering a non-stimulant to treat if we're wanting medication.
and any general guidelines when buying supplements? It can get overwhelming just shopping blindly and specifically probiotics.
Sorry, could you repeat that question? Oh, general
Sure.
guidelines. Oh gosh,
Guidelines.
it is very overwhelming. Probiotics, I don't really have a specific brand. I like Culturelle Flora Store. Just kind of the over the counter. They're all pretty similar. There are certain probiotics out there that are like tailored for ADHD, and I don't think that's a wrong thing to use, but you can also pick the affordable option and you probably will get similar results. Same thing with the omega-3s. There's no special one. I choose the gummy because a lot of my kids are younger and don't swallow pills yet. By the way, all these medications come in pills, but they're usually capsules that can be opened up. So these medications are easily taken because you can open them. Although I do tell my family, start practicing with pill swallowing. But I try to tend to pick the ones that you're going to use the most often, remember to take. That's the biggest thing I would say.
Do you have an opinion on the studies that imply that starting medication in childhood actually helps the development of the PFC into adulthood, the prefrontal cortex?
I completely agree with that. I think you can do a disservice to a child who truly needs medication by not treating them. It'd be like withholding thyroid hormone, in my opinion. So yes, I absolutely think that can make a huge difference in the role of restructural changes in the brain and the availability of those neurotransmitters. So yes, I think you can make a huge impact by treating early with ADHD. And we see that in the studies. We see kids who tend to self-medicate with other options if they're not medicated. So yeah, I think that can make a big difference.
This one comes up often. I work in the school setting. So how do you all see screen use in early childhood and or excessive screen exposure impacting children's ability to focus and regulate?
This is such a tough one. So screen time, dopamine release, lots of connections there, and that's why it's so addictive and something that's so hard to put down. We get a lot dopamine hit every time we look at the screen, and I think someone with ADHD also has the propensity to have a more of addictive personality because we're missing that dopamine release. So I think putting limits early is a super important part of ADHD. Again, everything within reason. I do not tell my families to never watch screen time ever. We need to be getting our work done. If we haven't gotten our work done in school, there should be no screen time until that happens. There should be no screen time an hour or two before bed. We need a little time for our brains to decompress, to rest, to prepare for sleep. And if we're getting exposed to that blue light from screens, it's telling our brain to keep staying awake, keep watching, keep binging. So we want to definitely put some really good precautions on screen time with ADHD. I should have put that in my presentation because it actually is a really big part of the non-medication part of treating ADHD. Mm-hmm. But I think that really falls on the parent to have really good structure and rules. One thing with ADHD that I really stress is routine. Routine is so important for an ADHD brain. If your brain knows what to expect next, it's going to be so much easier to get that task done than if you're just kind of scattered all over the place all day. And so if you can keep your life in a routine as best you can, you're going to see such improvement in behavior throughout the day. And that includes screen time. If your routine, so this example I give is my family. We used to let my child watch, we were in survival mode with twins. We used used to let him watch TV before school because we were just dealing with twins and what is going on. When we would turn that TV off, it was like meltdown central. We couldn't get out the door. We were like, we have to stop watching TV in the morning. This has to be our family's new rule. Now my family knows we do not turn TV on in the morning. TV does not come on until after school, until everything's completed. We get a certain amount of time to watch TV, and then before bed, it goes off at 7:30, and we have an hour before bed to just hang out and just be a family, kind of wind down. And so it's going to look different in every family. But if we're getting work done and we're not having behavioral issues, I don't get super crazy about screen time. I'm not going to just be like, never, only 2 hours. No, that's unreasonable. We want to watch a movie once in a while, right? But if you are seeing behavioral issues, absolutely, we need to put some good regulations in there. Parents need to have really good guidelines for families. And if the kid knows what to expect, they're going to push back, right? Kids push back on boundaries to test you because they feel that safety when that boundary is held. That is safety to them. And they test to see if the boundary is going to be held. But you want to hold the boundary in a gentle way. Hey, I know it's rough. You want to watch TV, but that's our rule in our house. We're going to hold this boundary right now just to keep you safe, just so we don't have meltdowns. And so hold that boundary for your family. I think that will make a big difference.
Perfect. What kind of sleep schedule should an elementary schooler with ADHD have? And what time should they be asleep realistically?
This looks different for everyone. Elementary school, man, they start like at 6:45. Sometimes the bus comes to my neighborhood to pick up schools. So it depends on when you're starting. And so everyone's family is going to look different, but I would try to aim for at least 9 to 10 hours of consistent sleep a night in an elementary age kid. So if they're taking a good 30 minutes to fall asleep, you need to factor that into your sleep schedule. And that may mean maybe you start gradually moving up the bedtime by like 10 to 15 minutes each night till you get to that bedtime that's ideal for you. Sleep aids are a really controversial thing right now. Melatonin one. I think we have a lot of recent studies too that make us a little bit wary about use of melatonin. I will say I do have families that use magnesium to help with sleep at night, L-theanine. So there are some good natural things out there that can help aid in falling asleep if we really struggle. ADHD, I call it ping pong brain. Your brain is just ping ponging around all the time. It's hard to slow it down. And so that falls with sleep too. When you lay down to sleep at night, if you have ADHD, your brain's just going everywhere. And so having something to help wind down, whether that's a really good bedtime routine, whether that's really good sleep hygiene, that can make a big difference. But yes, I would try to aim for 9 to 10 hours of consistent sleep a night for ADHD kids.
Well, thank you so much, Dr. Lehane. That was
You're welcome.
Incredibly informative. We really appreciate your time today.
No problem. I appreciate being here, and I hope you guys enjoy the rest of the talks.
Thank you so much. Now I'd like to introduce our next speaker. We've got Dulce Torres here, who will be sharing interventions in the home and the school. Dulce Torres is a licensed professional counselor supervisor, board certified coach, and associate certified coach. She is the founder and CEO of Avant-Garde Center and Brighter Horizons Group. Since its inception in 2008, Avant-Garde Center has been a leader in delivering innovative research-based counseling and coaching services, specializing in ADHD, anxiety, and depression. Dulce began working with school-based centers in 1998, and her commitment to mental health advocacy has continued since. Over the years, she has championed the integration of mental health services into school districts across Texas. Avant-Garde Center's dedicated team provides counseling and ADHD coaching tailored to the needs of parents, adolescents, and adults. In March 2022, Dulce launched Brighter Horizons Group, a school-based mental health and special education organization focused on bridging the gap between school counseling services and outpatient psychotherapy through a trauma-informed approach. BHG's embedded school services create a seamless continuum of care, fostering improved mental health and educational outcomes for students. Dulce is deeply passionate about empowering individuals to live life beyond limitation, striving to inspire students, educators, and parents alike to reach their full potential. Thank you, Dulce, for being with us today. I'll turn it over to you.
Thank you so much. What incredible conversation. I just wanted us to keep going. So let me bring these up, and hopefully I'm doing this the right way. Okay. this conversation so far with Dr. Gray and Dr. Lehane has been very, very interesting and providing a lot of information. That part I'm going to cover a little bit here, but it probably will come more up on the conversations and questions at the end. So I'm going to start with talking about the ADHD at home. But before that, 5 seconds. Look at this picture, write in the chat what you see, and I'm going to get out of this picture very quick, and I'm moving on. So there's an intention there. So hopefully you can remember what you saw there and write it in the chat for you. I will come back to that later. So I want to set up a little bit the stage here to talk about, to mention a few things. ADHD impacts the brain's executive functioning. We have heard that in our first two presenters. They have challenges in regulation, attention, emotions, and those executive skills that help us with plan, regulate, and persist are where we're going to have the most difficulties with. Kids often know what to do, but can't do it consistently. Many of you probably have heard about ADHD individuals are consistently inconsistent, and that is the truth. Also, it is a performance issue, not a motivation issue. So it's important to know that this is an attention allocation, that this is a performance disorder, and it's not a motivation problem. But I do want to share these next slides with all of you. My intention of these slides, I'm not a doctor. I'm not going to go down and explain all of this, but you have heard it throughout the presentation that this ADHD is a deficit in our neurotransmitters. And these are hormones / neurotransmitters that are needed in order for a neurotypical person feel very motivated. Okay, ADHD individuals are going to have challenges in this area. This is where we have deficits. So know that dopamine, serotonin, endorphins, and oxytocin comes together in order for an individual to feel motivated. So when you keep that in mind, parents at home with your children, with yourself, it's not again that they're not motivated, is their brain, it motivates very differently. So why creating some supports at homes? Why does that matter? So for me, home is kind of like that daily lab to really explore and train executive functions, to teach different strategies and skills to our kids, opportunities that we have. We need to structure our home with the intention to complement the structure and routines that they have as schools as well. And it's also by having us clear expectations, we can create a predictability that really will build safety and skill growth for our children's at home. So what are some of those challenges that we already have heard earlier today, but that we have at home? Some challenges is getting up in the morning, trying to get ready for school, the whole morning routine. Could be the evening routine, getting ready to go to bed. Could be about completing homework, refusing to go to school. And all of this could cause some emotional adverse on our children. And including some emotional dysregulation in the adults' parents. So there's a parent fatigue and also brings some sibling tension, especially when their routine is affecting every one of the individuals at home. So the skill behind the struggle. What is important in here is to understand that our prefrontal cortex, and we have heard some of this already, is developing as a child. So we need to teach the lagging skills of our children that they don't have in executive functions. And those lagging skills are going to be task initiation. These are some examples. This is not all inclusive. There's some more executive skills that we have, but some of them are going to be that task initiation, the working memory, the planning organization, emotional regulation, self-monitoring, this flexibility. So there's different strategies that we can teach our kids to develop those executive skills for them. Now let's dive into the strategy. What is important, and I want you to know, is that strategy is all about teach, model, and practice. Keep that in mind. Keep also in mind that is do as I do, not the do as I said, not as I do. This is very important. Our children are all the time learning from us. They're watching us constantly. They have a lot of time to see what we do, and they imitate us. An example, and I wish I would bring this picture that I want to give you, is this last summer, I spent time with my now 2-year-old niece. She was like 20 months at the time. And suddenly I see her with a little thing in her hand. I wasn't sure what it was, bending all the way back and looking at it. And then suddenly I said, what do you have in your hand? And she'd show me, and it was a phone. It's a cell phone. So she was taking a selfie. And I was like, oh, wow. And then I've noticed the family members around doing the same thing. So that's just an example for you all to know that sometimes we don't even realize that our kids are watching and they're imitating us. So that's what is important for us to know, that we're going to do as I do. So I'm going to demonstrate. That's part of the modeling as I'm teaching you, and we're going to practice the strategies. So where do we start? We start by regulating ourselves. For me, this is very, very important. Before we jump into correcting a behavior, we want to have a connection with the child. We have to connect. We have to build a good relationship. And if you have youngers at home, you could start now. You can build that relationship. If you have missed a little bit of your relationship with your child, with your preteen or teenager, is a little bit difficult at this moment, concentrate on building that relationship before we want to start correcting any behavior. Also, remain calm. Notice your emotions. What's happening to you before you want to correct? Look around. Look at the visual cues about also noticing what's happening to my child at this moment. Is this the best time for me to correct? And am I at a place that I can be calm to correct the behavior? Teach them how, when they're dysregulated, teach them how they can be calm, and just sit next to them and say, okay, I'm going to breathe with you. Follow my breathing. Or you know what? Breathe slowly. Do it. And instead of calm down, you need to breathe, calm down, and screaming and things like that. Just control yourself and demonstrate to them that as well. And always speak at their their level. This does not mean that you have to force your child to look at your eyes. This is what I see a lot of parents saying, that I am telling them, look at me, and they're not looking at my face, they're not looking at my eyes. This is not about looking at you and at your eyes. This is about you being at their level so they can calm down as well. And then they will, even if they're not looking at your face, they know that you're right there with them, and they're going to listen to you better. Also means that if it's a teenager, you might have to get in bed with them if they're laying on the bed, and talk to them there. So again, start by regulating yourself and giving the opportunity to notice what's happening around, and teaching them some calming strategies as well. So then what do we do when we move from here? How do we go ahead, and the things that we can do at home? This is not all inclusive. You have heard today in our two previous presenters that every ADHD person is different. You structure your strategies for that individual to help them is going to be what works for them, not what works for us parents, not what worked for one of your other kids. It is what works for them. But we do have to provide a structure environment. How come this is important? A structure environment is predictable and it helps with transition. You have heard today, and some of the questions has been, but what do we do when the child gets home and loses it? What's happening? So how can we predict our home and understand what is it that that person needs? Transition is very, very important. So transition, sometimes depending again on the person, could be anywhere between 3 to 15 minutes where the person needs a break, calm down, just disconnect from coming from school to entering home, which is a different environment. So that's what we need, predictability. Where do I put my stuff? And when can I put my stuff wherever the designated area is? Meaning if I walked in and I throw my backpack on the floor and I throw myself on the floor like, what an awful day, or what a great day, whatever it is, or I'm so tired, so sleepy, then okay, be okay with that, and then help them to understand the transition time. And by 15, 20 minutes, whenever that is what works for them, we're going to pick up the backpack, put it where it goes. What it starts our routine, a predictable routine of what we do at home. So have a place for everything that they need. Make sure that the area that they're going to work is clutter free. What's important about having something that is clutter free is that our reticular activation system, what we see, has an impact on us. And a messy area, even that we sometimes say as ADHD, oh, leave everything on my desk the way it is because I know where everything is. We need to understand that also has an impact on us. What we see, if it's messy or if it's so organized that I don't know where thing is, it's going to have an impact on me. So just be aware that you need to train them, you need to teach them where things are and practice on a daily basis. We also have to break things into steps for them. And this could look very different. Like if it's a younger child, brushing our teeth, having an image, having something up visually is very important. Like before, you saw that schedule, picture of the schedule. That's really good. It's very predictable. And it has some pictures next to the letters, the words, because that if they are not good at reading yet, the photo will tell them this is what we're doing now. So on brushing our teeth, if we want to help them to get used to brushing their teeth, whatever you routine is and their routine to brushing their teeth. Again, that means that people like to brush their teeth when they get up in the morning before breakfast or after breakfast. Whatever that is fine, but it is about what is the routine that we're going to teach you that now we do this, let's do it together. For some children, it's important that we really collaborate, work together, and that the parents are close proximity to help for these steps, this routine and expectations of them happen so they can take place. It's important that we have someone else, again, the modeling for them or being supportive with them. Kids will respond very well at that. Some other kiddos are very, want to do it on their own. So seeing a parent, an adult could be difficult, could be threatening to them in this, not threatening in a negative sense of you're going to hurt me, more about now you're watching me, you're not trusting me. So how do we build that trust? We start telling them, tell me when you need my help. I'm here for you. You just have to ask me to help you. And for our attitude when we go and help, again, is regulated, that we know how are we showing up with our kids. Because if we are frustrated, if we're mad, if we're running late to get to school, we're running late to get to work, if that frustration comes out, it's going to have an impact on them as well. Make sure that when you start with a new strategy that you're trying to teach your child and see what works for them, try it with baby steps. And baby steps, could be that, right now, when you're getting ready to start do homework, we wanted to do it at this place. Is this place works for you? Could be a chair and a table. Is it laying on the floor? There is a lot of conversations on parenting. Said, can I do my homework laying on the bed? There's nothing wrong. It is about how is that working from you? How do I measure that this strategy that you're using is helping you? So that's part of this whole conversation with our children as we set up a structured environment at home. And very important that when we are working with our children that have ADHD, our brain needs a more immediate feedback. When we said, oh, when you do this today, on Saturday, we're going to go to the movies or we're going to go to the park, and today's Monday, that's not going to help us to get the things that we need to do immediately, thinking of Monday. And that could help pretty much with a teenager. But for the most part, is that immediate gratification that is really immediate feedback. So you reinforce the effort, not the perfection. So what is reinforcing the effort is when you see that they really put their shoes in the closet, let's just say that, or on the rack that you want them, and you notice it, just say, hey, thank you for putting your shoes on the rack. It's not a conversation, it's not a dialogue. You just say it and move on. That little bit of immediate feedback stays with them. But if sometimes we see kids doing what we want them to do, and what I hear parents telling me is, but I don't say anything because then they're going to stop doing it. Not true. I think that immediate words from us of affirmation and words about, I noticed what you did. That's it. It's not a conversation. It really will have a more positive impact on that child. And again, that's the part of the focus on progress, not outcome. And these are going to connect a little bit with school. When I hear parents talk about school progress and that they're doing better, a lot of the focus goes into grades. And we don't put attention to grades. Is not the best measurement about the child learning and improving. Why many of you have said in here, our children, ADHD individuals, are extremely intelligent. They can do the work. But if what we want to focus is on the process, on how got them there. So is we want to understand what are they doing. They study. So when you get a report, they say, last night, all the week that you've been studying for this test, it worked, it paid off for you. Good work. So it's understanding and connecting that so their brain understand, okay, I did A, B, and C, and this is the end result. This is the outcome. But we want to focus in that process of what they did. It is very important to build family routines that work. Every household is very different. We are very different individuals. If there's two parents in the home, mom and dad can be very different on how they like their routines. So sometimes we put in place and we do what we know, what we learn ourselves as adults, right? So that's where we're going to start. What we need to put attention is what works for my child. I'm going to use the word transition a lot because I want you to understand that every time that I had to stop an activity and start another one. There's a transition. And it's kind of like almost 3 steps. Stop what you're doing, connect your brain to what I'm going to do next, and then initiate the task, engages in my next step and what I'm going to do. So when it's bedtime, for example, which is one of the challenges I hear all the time, is how do we prepare bedtime? So if I want my child to be asleep at 8:30 at night, and I know that the child, as soon as I said bedtime, is going to start looking for reasons to spend more time awake, then it's like I'm going to build that in. So I'm going to start my process maybe at 7:45, where I give the first warnings to helping them to transition. As soon as you show finish, or as soon as you finish doing a game, whatever it is that you're doing, this is the warning for you to start transitioning and understanding this coming to a stop. I will recommend never have a child doing electronics before. That's going to be more difficult to stop. But if that's their routine, you start with the warnings and preparing them to transition. And then by 8 o'clock that they stop, I know that they're still going to find excuses and reasons to be up, and they want me. Most of our children, they might not say it verbally, but they do want the time with their parents. So that's when I have to decide I'm part of this process, and then mom and dad alternate, or mom and dad have one it has the morning routine, the other one the night routine. However it is okay, we're going to read a book, or we're going to look at the pictures of a book, whatever it is, or we're going to lay down on bed, and we're going to talk calmly. We're going to do some breathing exercises. We're going to notice our body relaxing. Is building that transition, so you know that now you have the child in bed, and now you can say, okay, at this time the lights goes off, or the lights are dim, whatever it is. But by this time is 8:20, 8:30, you're able to leave that child's room and let them settle down and finally go to sleep. So that's part of that preparing and planning. How do I want my morning to look, and how do I want my night to look? So I, as the adult, needs to understand how I want that. So I will make a plan, but accordingly to when I want them to fall asleep. Homework is the same. When do we want to do homework? There are in the families that the homework is done after dinner. There are families that dinner time starts as soon as they get through that door, 4 o'clock, and others have dinner at 8 o'clock at night. All depends on what are all the activities that happen after school. So again, being very consistent, how is that routine is going to look, and understanding that every activity we have before one finish and the other one start, there's a transition time. And then back to, again, like it says in here, use calming bedtime routine, which is for everyone. This is not just for one kid only in the family. And when it's change of ages, we talk about it. Oh, you older, you are 15, you can go to bed at 10, you have all the responsibility, but you siblings that are, 9 and 10, they have a different routine. It is okay, but be consistent, and then make sure that the whole house gets calmer, meaning if there's a TV too loud, that's going to distract the person that you're trying to put to sleep. So it's all those little arrangements that we have to talk at home and improve ourselves to set up this routine. Now, point of performance. If you never heard this term, I invite you to look at Russell Barkley, one of the pioneers, research individuals that study ADHD and has lots and lots of books. He is in YouTube now. There's lots of information about him. When we are teaching a skill for our children, it is important that we have everything at the point of performance, that everything is in the area where they're going to do that task. If it's homework and I do my homework typically on my desk, what are the things that I need? Where is that I have everything at a really easy reach rich. And then also might be that I have things put probably in a see-through container, clear container, so I can see what is in that container if that's the way I have it organized. But the importance is that they need to understand everything is going to be in the same area. This is a picture of a perfect kitchen. Everything is put up nice. My house will never work like this. People will go crazy trying to find out where is everything. And then the example of the coffee, that you have the coffee maker, you have your appliances, and right above that is where you have everything that you're going to need, especially if you're going to make a coffee cup, or coffee and all that. Your cups, your coffee beans, anything that you need is right in that area. That's what the point of performance is. And this also is very important when we are teaching our children to be part of the family by cooperating with chores. We all do chores, so whatever the responsibility is, what do they need in order for them to do them? So that's part also of very important to know when we are teaching our children their executive skills by doing chores and helping with that. Important when it comes to home. So I mentioned a lot about you checking in with yourself and your own emotional regulation. So what I want you to be very aware here is that there's some things that we need to be careful on how we communicate them. You have heard through this presentation today in the morning for the other two speakers about ADHD individuals always identified as you are lazy, unmotivated. So key points. Don't say how important it is that they do something because they really know it. Don't remind them of their errors with the hope that they won't repeat it because they know their mistakes. And don't say should, need to, because again, they know it. And it's about what we can do to help them to find a different way of them using the strategies, the techniques that they might need for themselves. So saying that, it's important that if I structure my home and I know what are the strategies that work for my child, I'm very aware of them, then let's share this with the school. If I know and I understand transition, most teachers understand transitions, but sometimes I have to be clear and explain and maybe be part of my 504 plan or the IEP that my child will be giving 5 to 10 minutes to transition from one activity, one end of the class to start the next. So it's important that we share what works, that we align the languages and strategies. If the teacher shares with us something that really, really works very nicely for them in school, and I'm hearing about it, I'm like, can I do something similar at home? And I will ask my child. Everything that I want to put in place is not the ideas that I come up with. And let me just tell you, when you heard how long I've been working in this field, in the 90s, when I was learning so much and my child was like 6, 7 at the time, I wanted to implement everything like the book said, everything, but it didn't work. It got me more frustrated because I say, I'm trying to do it like they say to do it. What I missed was the communication part of sitting down with my child and said, hey, I learned this. Do you think that this will help you? It wasn't until my child as an adult told me how much whiteboards will be very beneficial and help him. And I never had any whiteboards in the house until he was then in the high school and getting ready to go to college. And that's when I learned that strategy works for him, but it would never done on me because I'm a paper person. So see the difference and why it's important to talk with them and communicate. Find a tool for you and the school to communicate. That could be that you have a designated piece of paper that is in one of the binders or folders for them to send you messages. Talk about how that communication is going to be, or it could be that they're going to email you. And you do want to encourage them to email you when your kid is doing good, at the same time of when they're having a challenge. You want to know it all. So encourage that communication and always listen to these not as a reflection, oh my God, I'm embarrassed for what that happened. I can't believe it. Because it's not about us, it's about our child. How can we help them? And what is the question? And ask the child, I understand this happened. Tell me what happened. Tell me your version. So that communication is really important in order for you to create the best strategies at home. So a reflection questions for you all here as we get ready to stop this portion before we go to talk about school directly. So what's one home routine that creates stress for you? And what's the small change that you could make for yourself that will make it easier? That's my question for all of you, parents and providers, all of you here. And as I ask that question, and we're going to be transitioning to our next conversation. So as we do that, let me stop here and ask what questions and see who wants to tell me what is a routine or who wants to make a comment about what you can do to make things better for you right now. One little thing. I'm going to stop sharing. This is going to be to you questions and answers in here before we transition to the next presentation.
I see in the chat that to prepare the night before, putting things away. I have marked baskets around the house to put things in so I can bring the whole basket into the room. It goes in.
I love the strategies.
Yes, love the idea of focusing on the positives and things that are going well. Sometimes, we are so focused on what's not going well that it can be difficult to see the bright spots.
I love it. I love the statement. I can make my bedtime more consistent.
Yes.
And I think that that's the hardest, biggest challenge for us parents at home. We're humans as well. We also have either working, doing different things that we're exhausted too. We want a break. So knowing that our role as parent continues, we have to be with our children. We have to be the one regulating what they're going to do next, when they need to be asleep, the shower, eating, the sports, the activities. There's a lot that we have to manage. Managing your own executive skills. And if you are a parent with ADHD, then it's like, what is the strategies I'm putting for myself so I make sure that I'm successful and my children are successful as well. So it's a lot.
Lots of structure and planning
I
and
know. I love it. So I'm gonna see, did anybody answer? Yes, they did answer. I see some of the faces about that first picture that I put there very, very fast. uh, and some people saying that was a tree. Okay. Other people said a tree and two people. Another one says two faces. Lots of trees and leaves. Uh, faces and trees. Okay. I will bring that picture back in a moment. Is there any other question in this part right now before we jump to keep talking about school? Perfect.
All right. Thank you.
Okay.
Dulce, I think we're ready
You're
to keep on
welcome.
going.
Yes, let's keep going. Make sure I do this right again. Oh, wait. What happened here? Stop sharing. I didn't see my screen.
I was going to say, we saw your screen, but not the
Oh,
presentation.
you,
Here we go.
exactly there.
We can see it.
Okay, perfect. So, how come this picture here that is all about perception? All of you were right. What you see at the beginning, what you saw later. So yes, there is a tree with leaves, there's two faces, there's a trunk of the tree. Some person told me sometime that they just saw a base. We see different things. And what I want you to take away about this is that your perception is your perception, and there's nothing wrong and there's nothing missing. There's not a right answer, but it's an opportunity for us to have a conversation when our children see things different. And it's for you to be curious and ask, okay, let me understand your point of view, and let's see how we can come together and come up with a decision on whatever we need to do. So that's the intention of this perception of picture here. That is, we all see things differently, and it's allowing that is an opportunity. It's not to look at who is right, it's to look at what do we do to make things better for ourselves. So let's move to talk about ADHD in school. I heard some questions about 504 and IEP. I'm not addressing that. Is very specific to that here, other than as saying to you, ask for those services. But we can talk about it, and there are more individuals here also in the group. I understand, I know, that have experience in this area. But ADHD in school affects their readiness, not intelligence. We have heard throughout all our morning that ADHD is not the lack of knowledge and the lack of intelligence. It is about the skills and readiness. And is what we need to communicate that when it comes to behavior, that is a deficit of a skill or what happened in school. So when would they talk about the behavior challenges, what we want to look for is, what's the lagging skill? What is what they don't have that we need to help our children in school, and what we want the school to do for them? Some common challenges is incomplete work, interrupting, talking too much, forgetfulness, social rejection. This picture of getting some work back, and this right, the feedback from the teachers so big, and parent signature and wrong, incomplete, that is a no. We need to work with our teachers, and if we have any teachers in here, we need to work with how do I provide the feedback to the students. And yes, we need to tell them that it's incomplete. Yes, we need to parent to sign it, because we need them to acknowledge that they understand it's incomplete. That's totally fine. It is how we're going to communicate that to the person. Okay, so these are some of the challenges. And through the first two presentations, both Dr. Lehane and Dr. Gray talk about the different school challenges. And you know the challenges that your parents that you work with are telling you, or you yourself, I notice it at home that you're hearing from the teachers. So we need to understand what is the underlying problem, skill gaps, again, lagging skills in here. So when it comes to executive functioning, which is that set of mental skills that help us to manage our time, attention, and behavior in school, if we have lagging skills, then what am I going to do here? When the teacher is talking and is giving a lot of instruction, talking, and there's nothing written down for me to look up and know this is what we're doing, or she's talking when I'm at the beginning, when I walk into a room and I'm still trying to sit on my chair, get my stuff ready, I don't recall everything that she's saying. And children sometimes have very poor impulse control, the ones that blur the answers, the ones that are constantly maybe just talking to the neighbor. What did she say? What did she say? What did she say? They have this time blindness. So how do we help them? And schools are the next best place after home to teach executive skills because we're using them every single moment. So the teacher could say, there is a clock for you to look to see the time pass. Their teachers could have as an accommodation a sand clock that person is trying to use themselves. They say, I have 3 minutes to get my everything settled on my desk. My book out, my notebook, I have 3 minutes for that. And they could have a little sand clock that they can use. That's a strategy. But it's about what are those underlying lagging skills that we have to build their strategies and techniques so they know what to do for themselves. Proactive classrooms. And I think that you're going to have teachers, many of you have experienced teachers that are really, really good at changing their environment to accommodate their students. There are others that are still very, very traditional. So here is parents becoming an advocate. After we talk, we're going to talk early about communicate with your child. If you're going to ask for the school to do something, make sure that your child understand what you're going to ask for them and make sure that they know how they're going to use that intervention or strategies that is put in place at school. That's very important. Many times the kids that I work with, when I ask them, what is in your 504 plan? What is in your IEP? They don't know what I'm talking about. And I do expect that any child that is kind of like 11 and up to understand and to know when they have been either in a 504 or a special education system for a little while. I do expect them to know. But we need to know as parents that not always the school is going to go over that with them. It is also our expectation that I have the plan and I'm going to let them know, hey, expect this. You have options to use this, whatever it is. So minimizing distraction, how can we keep noises down? But what if the ADHD person is the one that needs to be making the noise for whatever reason, right? So now what is the strategy that that person needs to minimize their noise making at that moment? And sometimes it's at a tick. I observed a child that it was constantly making a noise with his mouth, kind of like almost a whistling, low, soft, but you can hear it. Well, then what's the strategy for that person? It's going to look different. Okay, but minimizing those distractions. This first picture here about that the exercise ball, I will tell you more than now 10 years ago, I was in a school and in the special education room, and this kiddo was constantly moving on his seat. And I said to the teacher, knowing that no one is doing this in school, can we bring an exercise ball for that one student? And everybody was against it because they felt that that was going to create more challenges for all the other students. And I said, everything is about providing information, preparing them for the change, and then knowing that when this student was in that class, he had to use that ball for him. But at the same time, when the exercise ball was available, the other student can rotate. So we incorporated that to the class. And when I visit the next time, the beauty of this is I noticed this student sitting on the ball with the legs folded and balancing on the core that I was like, how is he doing that? And you know the effort that it takes to balance on that ball when you're folding your legs. So you're using a lot of core. He was very straight, but he was all engaged. And the teacher said that it was the best thing because the activity, the physical activity of him staying steady there, he was able to concentrate and did the work. Classmates' feedback was he was less interrupting them less by doing that, by having the ball there. So you see, that is just, again, thinking out of the box. What can we do? Again, every school is different. Every teacher is different. So it's that communication and how we can make it better. It is important. I talked about the reticular activation system before. We need to see a schedule. We need to know what's going to happen next. Back to that predictability for them to prepare themselves. Oh, it is this time I'm going to do next. And it's all about how we present these strategies to know how the person is going to take them. It's not about forcing them or threatening them. It's about showing them, hey, there is the clock. Can you read the clock? Is it okay? Do you work with a clock? If that works for you. If not, what other the tool works? Like it's a timer. And I talk about this little sandbox, sand clocks. So, I forgot how you call those timers, those little things now. But the intention is, again, how do we change the environment to help that person? And remember that accommodations are to level the playing field for that person who needs those accommodations. So when they say that the school might not want to work with you and say, no, we don't want to do that, it's like, well, we want to level the playing field for my child to be as successful as all the other students as well. Okay. A fidget corner or improved focus, that's really good. If they get distracted, if they need to ground themselves, what are the tools that they can use? I love fidget toys, but sometimes some fidget toys could be a distraction. So how are we going to use the fidget toy? It's not about not using it. It's about how we're going to use it and how we're going to practice. That's what's important in here. And instructional support, again, the visual, the verbal, they're being very clear. They're expecting the teacher to sometimes to go to the student and probably repeat the instructions close to the student that might get a little bit more distracted. So that's a strategy that I don't have to change my whole classroom. Whatever strategy I use and implement, I can probably use it for all of the students. But if there's something very specific, like I want them to hear my instructions again, and I noticed this this was a 10th grade class. This was biology. I was doing an observation, and this teacher, every time that she will talk, she will go to the student that I was observing and the one that had the ADHD, and repeat the directions close to him. And then he will repeat them to himself. So that was kind of like a cue. Again, she did that throughout the whole hour of the class. Any changes, anything that needed, that it was a next step, she will walk by close to that student. So all the students sitting around him had the benefit of hearing it a little closer again, but the whole class was given the instruction the second time. So that kind of strategy works really well. And when we want to know, are they doing what they need to be doing at this moment? Did they heard me correctly? Then go individually. Avoid saying something. Hey, Johnny, did you understand what we're going to do next? Or Johnny, what are you doing? No, we want to diminish any kind of shame, embarrassment, anything like that. We want to really, again, walk by. And those are things that we can ask the teacher, we can ask the school when we make a plan of accommodations for our children on how they can approach our kid and try to prevent any triggers of shame and disengagement at that moment. Well, sorry. There. I do believe in teaching a lot of executive function skills. That's what this whole presentation has been about for home and school. How come? Because we talk about it. ADHD is a disorder of the brain, and the prefrontal cortex is where our executive functions, those mental skills that help us to do what we need to do, are located. And they need to know how, when I'm going to use my strategy and what is it that I need. So teaching that could be the teacher could be the person coaching the student. Parents could be the person coaching at home. It's not just go and find all the additional services, which is totally fine if you do, but it's also about the teacher can be that coach, the parent can be that coach, and when you're teaching the skills, be very explicit, be very clear. This is the organization skill. What works for you? If you have a kid in school that their locker is a mess, and this is one thing that we also did, is we asked the student, do you want your locker organized and clean? Permission. Then this is what you want to change, commitment. And they say, when do you want us to work on this? And we plan it, we prepare him, and then we open the locker and we started working. And I was not the one doing, I was saying, okay, where did you want to start? What in here did you see that you want to start first with? And of course, they put the backpack out and says all the papers that are inside these backpacks. And that's how we started, baby steps. And we were talking out loud, especially this is something for home as well, is really, really important and helpful. When we are talking aloud, we're helping them to process the information. We're giving them the opportunity to think it through, to understand. Now, when you do any activity and you're doing coaching, time is limited. You don't want to overwhelm a person, and we don't want to teach everything immediately. Everything is baby step. If we're going to use a timer, it's like, which timer? How are we going to use it? This picture over here of the different timers, and there is a lot more out there today that people can choose. So give them the option of what is going to work for them at home or at school. How do you want to use it? And then talk to the teacher about it. If you are organizing with the teachers their folders, and they're going to be color-coded folders, it is important that they know, and that if it's the teachers providing what color is for what class, then fine, we follow the rules. But if they have freedom of choosing, then it's like what color you would like for science, for history, for language. Again, it's including them, engaging them in the process. And this is something that you can share with your teachers. Model planning. I think that this is very important, that the teacher, back to speaking aloud and saying, okay, this is what we're going to do to plan this next activity, and walk them through same interventions that we can use at home. So executive function coaching is very helpful. Positive behavior supports in school. This is something for you to identify what will work with your kid and give them to the teachers and help them. I put token system economy here. I have my own opinion that works, doesn't work, but typically every person is different. I think that the younger the person, using stickers and token has more value. As they grow, the behavior plan has to change as they grow. And sometimes it's in the same school year, it might be that the plan has changed 2 or 3 times, because ADHD individuals like the novelty of whether the feedback that they're getting and the support, and then it gets old and I want something different. I need something different. So it's knowing that we have to be constantly changing it and making sure, is this strategy really working for you right now? I hear a lot of parents and teachers said, but it used to work so well. Or last year, they used the planner the whole time. This year, they don't want to. That's okay. What are we going to do differently? So the planner, the paper planner is not going to be this year. What is it that we're going to do different? And these challenges that I'm talking about here, we have them through our whole ADHD lifespan. It's just going to present and looks different. But even adults might been using some technology to help them to organize and all that, that another adult still use the paper planner or a journal. That's me. I need to write because I need to write things down so I can remember and connect it with my brain. Other people like the technology. Nothing wrong with that. Is we adapt and we change and we teach again. But knowing that, creating some support, kids sometimes, again, they pat on the back, the good work, good job. I see that you completed that. Thank you. Is it just enough for that individual to get that positive feedback? Um, I think again, I talk about communication, conversations. It's really important to when we acknowledge that a child having behavioral challenges, I am the belief that the teacher can start by asking that student, what do you need different? What can we do here for you? This conversation, as I said before, the teacher has to regulate her emotions and wait that the child is ready to have that conversation. Okay, so if we want to correct something, a behavior, we first have to be emotional regulated in order to do it. So that includes also the teacher. So it's important that we can ask our children, I understand that you're having these challenges in class. What do you want to do different? What will help you? I had a teenager, 11th grade, telling me it doesn't matter what I ask, they don't know how to help me. And I was like, what do you mean by they don't know? And she clearly stated to me that when she asked she's in their the SPED teacher for help on a specific subject, they didn't understand the assignment and the work. And I was like, whoa, okay. So what are we going to do about that? If she is using this strategy of asking for help and the person doesn't know, then what? Because what she's learning, what she internalized is don't ask anymore. They don't know. So this was something that we brought to the art meeting and have this conversation there to know what are the strategies that she needs when she needs support in some sort of assignment and work in school. Okay. Collaboration and consistency. The way that I ended the first presentation about home and communicating with school, again, this is that piece of having that collaboration and consistent and communicating regularly with the parents. So you, as a parent, make sure that your teacher is communicating regularly with you. If you work in a school district, make sure that the teachers and counseling understand how we're communicating with parents. And that could be through a communication log, through email, through a journal that goes back and forth, whatever works for the child who's going to be carrying this back and forth, and the teacher and the parent. That's the conversation. And again, to emphasize the importance of tell me when he's doing well, when she's doing well. I want to engage my child in a positive way all the time when I talk about school. Okay, it is a team approach, which is the teacher, the counselor, the parent. If your child is receiving services, I always encourage to include that therapist, outpatient psychologist, whoever else is working, is to include them all together. Accommodations for ADHD. Yes, you heard this morning, I believe it was Dr. Gray talking about ADHD is in getting my thoughts together here, is one of the qualifying conditions for special education of 504 under the other health impairment. And so, yes, if your child is having challenges in school, and the challenges in school, again, might not be always behavior. That's always where got us started, but not always. It could be that inattentive person that is so distracted, daydreaming so much that is not able to turn the whole work on time, or is spending hours and hours at home trying to do all the work so they can turn it in the next day, and it's a lot. So then what is it that we can do? What kind of accommodations we can put in place for that individual? So you can have a 504 plan and you can have an IEP. The IEP is the one that's going to go specifically to how something is taught. The specific instructions is where you can have a behavior plan. You can add the coaching into the IEP as well. And then again, the accommodations and modifications are to level the playing field for the person. That's the intention in here. So the question for you, what classroom change could you ask the teacher, your school, to do to reduce frustration for that teacher and for the students? Can you think of what is it? Back to the same question that I have as the home, is it what from these conversations have you been hearing that you would like to ask the school to be more supportive of your child, to continue to support your child? Saying that, this is, as we go back to that, is takeaways, is that remember ADHD is about building skills, not willpower. Consistency is not the intensity, and collaboration equals best intervention in here. And I should have put in there also the regulating ourselves, our emotional regulation and managing. This is at the end. Do you have some references there for you to go to? I noticed that the first, Dr. Gray put already chat into your presentation and all that. So this is where you can go and get several tools. Hey.
Hi, I'm looking at the chat. There's lots of good ideas, giving breaks when needed, visual schedules, timers, breaks. Really great ideas for our students in our classrooms.
I do want to acknowledge this is time consuming. This is being very intentional and sticking to it and being consistent. Many times the feedback I get from children and adolescents when something has been working and stopped working, when I ask how come it stopped working, remember that I said sometimes you have to change the plan. It stops working because the adults stop doing it, their part.
Yeah.
And it's like, okay, so it was not the plan and the strategy is working, but the adult stopped because we're parents. I get it. But we need to be aware, like, how do we get back to being consistent? Especially if we have ADHD ourselves, how am I helping me to be consistent for my kiddos?
Absolutely. Well, thank you, Dulce, for sharing all of your expertise.
Thank
Any
you.
other questions before we move on to our final speaker for today?
Yes.
You can either type them in the Q&A or the chat, or if you raise your digital hand, your virtual hand, then we can unmute you. You were so thorough, Dulce. Thank you so much.
Well, and we all day been talking about this, so it was
Yes.
good together. So it's good.
Really
Thank
good
you so much.
information. Thank
It was my
you.
pleasure.
Well, next, I'd like to introduce our final speaker who's come to share with us her personal story with ADHD. Kate Jones is a licensed professional counselor associate supervised by Dulce Torres. She specializes in working with teens and adults with ADHD and autism from an affirming framework. Kate sees clients at Healing First Counseling, located in North Richland Hills. Kate has lived experience as a person with ADHD and autism. Welcome, Kate, and thank you so much for sharing your story with us.
Hi, everyone. Thank you so much for having me. I have loved hearing some of the stories and the feedback from some of the different presenters. A lot of them are things that I wish were in the know when I was a kid with ADHD. I was diagnosed in 1992 in kindergarten because my kindergarten teacher happened to know about ADHD. Her son was diagnosed with it, and then as a result, I was diagnosed with it. Um, but before that, at 18 months, I was sent to a neurologist because my pediatrician was like so overwhelmed with my hyperactivity. So when my mom said, "Well, why are we going to send her to a neurologist?" He said, "Just look at her." I was climbing everything. I was getting into everything. I was so fast. I was all over the place. And I didn't sleep through the night till I was 4 years old. So many different things happened. So 1992 I was diagnosed with ADHD, and I started on Ritalin, which was kind of the only thing at the time. Um, we did like a variety of interventions, and uh, some helped and some did not. Definitely the things that I had some input on helped a lot. But some of the things that I've noticed as I was growing up is with practitioners, and maybe now with more practitioners having ADHD themselves, it's a little different, but there was a lot more focus on the external symptoms. So like the symptoms that caused trouble for other people. So if I was able to sit still in my desk because I took my medication, um, everyone just assumed that it was working and that I was doing well. And I, at the same time, was still having a whole lot of trouble paying attention, a whole lot of trouble managing my emotions, a whole lot of trouble with social skills and interacting with people my age. Um, and so that's been one of the big things in my career is focusing on making sure that we're paying attention to a person's internal experience as well as the symptoms that bother everyone else. Um, I apologize for whatever is happening to my voice. Um, with things that helped me at school, a lot of it was building into that interest, right? Like making it creative, making it interesting, making it fun. I have this memory of being, I think, in fifth grade, and we were trying so hard. I was trying so hard to understand adjectives, and I just didn't see the point. And I was absolutely losing it. I was crying. And I came to my mom and I was just like, I just don't get it. And so she said, okay, close your eyes. There's a stage. Who's on that stage? And I said Stephen King because I thought that was really funny. And then she said, okay, what is he doing on that stage? How is he on that stage? Is he, so like that helps me understand the function of the adjective using my visual brain and using like non-academic language, I guess. Um, Another thing that really helped me growing up was the use of a study skills teacher. I would go to my godmother's house on in sixth grade, and she would sit down with me and have a routine, right? We'd sit down, we'd watch Wheel of Fortune, and then we would do homework together, having someone body double with me by sitting with me and just not doing anything else that was distracting, sitting next to me, making sure we knew that it was not overwhelming. And if I had a question, I could ask it. Um, this separated me from like the overwhelm of like the emotions and the pressure that we'd kind of established at home because my parents were so stressed with like, why can't you just do it? And also, I need to cook dinner. And also, I need to take care of your brother. And also, I need to do all these things. And also, my dad's working nights now. So my mom's having to do all five of those things at once, somehow. So having like an external person who is not as emotionally invested in the situation helped a whole lot when like certain aspects of the place couldn't regulate. Um, I was one of those perfectionists that Dr. Lehane talked about. I was very perfectionistic. I needed high grades. I needed everyone to like me. I needed my teachers to like me. And I often let that color my self-esteem a whole lot. Um, and so I think I would have benefited a lot from learning more about social skills and that kind of thing and building self-esteem in a way that I don't think we were prepared for back then. Um, we, I continued also in school to like have the ability to do like minimal effort but succeed really well. So I think if my teacher hadn't caught my ADHD so early, then I would have been one of those undiagnosed people. Um, I went on to, I'm trying to think of all the things I want to say, and I don't see anyone's faces. So that's what's making me pause a whole lot. But I went on to go to college and had taken myself off of my medication without telling anyone in senior year of high school as an experiment. Um, and then like after a month, told everyone, "Hey, have you seen any difference in me?" And they said no. So I was like, "Great, I don't have to take it." And then I went into this deep depression in college and somehow managed to get through without medication, even though I would say like the classes that I had to focus on that were not as interesting or more overwhelming were still the ones that I did poorly on. Minoring in art probably saved my life in that time. Um, I went on after that to get a master's degree in family and child studies, thinking I'd be a child life specialist, but I fainted in my intro class because I couldn't handle the procedure videos that they were doing and moved towards parent education. And then finally in my 30s decided to go back into my original idea, which was counseling. Um, I think a lot of the things that have been said so far um, about regulating yourself as a parent or as a caregiver, as a teacher, they're so important. I was so good at knowing when people were frustrated with me. I was so good at knowing when I had disappointed someone. I was not always good at knowing when I'd done a good job on things. I was not always good at knowing that I was good at something. And the things that I did know I was good at, I clung to like they were my whole identity. I was very, very attached to being smart and being the smartest person in the room. And if other people were smarter than me, it was very identity shattering. Um, so I want to give a lot of space for all of you to ask any questions that you have from someone who remembers a lot of their childhood. Um, I don't see anyone with okay, how do you cope with autistic inertia combined with how difficult task organization is with ADHD? Okay, so this is where special interests come in because when I was a kid, I didn't have cable, so I watched a lot of PBS, and I ended up watching a documentary on vaudeville. And And the way that they structured the acts was they had a really attention-grabbing act to bring people in from the streets as the first act. Um, the second to closing act was always the best one, the most talented one. And the final act was something that drove people out of the theaters. So I kind of started structuring my homework in that way. How can I get myself into it by doing something that's interesting, and then save the easiest, most blow off thing till last, while still like getting that arc of attention. Um, so that was the that was the way I worked with that inertia and task organization thing. But a lot of it, Alexa, was me getting help from other people. When your child is still dealing with not having their prefrontal cortex, those executive function skills fully developed, you kind of are that for them. And so lending your prefrontal cortex to your child is kind of one of the ways you help them. Um, I see that someone had a raised hand, um, but I don't see it. So go ahead if we can unmute that person. Yeah, Scott. I'm seeing people with raised hands, but I'm not hearing them.
Same. Scott, let me see if our
In the meantime,
medium.
while we're figuring that out, I'll answer Mandy's question.
Sure.
Some others, I'm sorry, Erin.
No, you're fine.
Some of the other specific strategies I've used to help myself, like Dulce said, they change a lot over time. So what works one week may not work next week. And I have to be okay with that and not beat myself up about it. Some specific strategies, working with other people who are also working on something, that body doubling has been a big thing. Moving from place to place. I did this a lot with homework. When I couldn't stop the wiggles, I moved to sit on the floor in the hallway. I sat on the landing of the stairs. I perched on a ledge that you had to climb to get to do my homework. Anything that had to engage my body in different ways. And in grad school, one of the ways that I did that is I would start at a library. Then I'd go to a coffee shop when my attention started lagging. And then I'd go to a park, and then I'd go back home. And, I'd move around a lot just to help engage myself that way. The way I motivate myself to initiate tasks that are less motivating and rewarding, I do I do something called the push the barrel down the hill action. So like if there's a conversation that's difficult, you have a phrase that's like going to push that barrel down the hill, and it's going to pick up momentum. Like, hey, so I really wanted to talk to you about something important. And then you can't back down from that, right? So I'd be doing something like, all right, I really need to do my notes, or I really need to do my homework. I'm going to tell someone else that I'm starting my homework. I'm going to tell someone else that I really need to get out of bed. And for some reason, that helps me. Those are a lot of the things that I've done when things are less motivating and less rewarding. Other things I've done are little dopamine things like, okay, let me do one thing that just makes me excited real fast so that I'm not dreading everything. Boredom is physically painful for me and for a lot of people with ADHD. It's very overwhelming. Listening to music sometimes helps for me. It's very back and forth, right? So sometimes music helped in that I was able to engage another part of my brain. But if it was music with words, it was hard, right? So, um, again, it's back to customizing it to the person. What helps you? What works for you? Um, but yeah, boredom is painful. It's physically painful. Scott, what was your question? If you could unmute.
Can you hear me?
Yes.
Yeah, I was just asking, like, as a former teacher, what's one or two things that teachers told you that, like, spoke into your life that really motivated you to keep going and keep trying?
Okay, so the easier answer to that question is what they did that did not motivate me to keep trying. Like treating me like a special case. Like I got the lead in the Little Red Hen in first grade and my teacher said, because I knew you could do it. And I was just like, ew. Um, teachers, like, and I'm gonna call her out, Debbie Gunup, if she's ever out there anywhere, um, who recognized what was special about me and encouraged me. People who, they saw the things I was interested in. Like I was writing a lot of poetry that year, and she would ask me to write it down and sign it and draw a picture, and I never did it. I never remembered to do it. But the fact that she wanted that, that I knew she was on my side, that I knew she was a fan was so big. Hearing people saying things that were like, you're good and timely, right? Not making me an other, not making me an example, because I had teachers in high school who'd be like, Katie's so tenacious, look at her tenacity. And it was just like, you're making me a target now. Um, but people that told me and took an interest in me, people that talked to me after class, it didn't necessarily have to be a specific thing. It was just knowing that they were in my corner. That was really a big thing for me. Does that answer your question?
That was great. Thank you.
Thank you. Okay, Jennifer, you're the next person that had that hand up. You should be able to unmute maybe if that was the issue. Oh my gosh, yes, I had tantrums as a kid after school. Oh my gosh. My mom is FaceTiming with me right now because she wanted to see this and she just started laughing so hard. Um, Huge tantrums. This is a really weird thing, but um, if you've practiced yoga at all, there's a practice of putting your legs up the wall to help relax. I realized later in life that sometimes that when I would get home from school when I was very young, I would lay down on my back and raise my whole body up to where just my shoulders were on the floor, and I would balance a pillow on my shins and flip it around. And it's just this, and my mom's nodding right now. It's this occupational therapy aspect of kids will seek out the input that they need in order to get their sensory needs met, and it helped me so much. So, allowing me to have space, having a quiet space, um, giving me something that gave that like input that I needed was so, so, so helpful. Um, I got incredibly overstimulated as a kid. We had a long drive back from school. My brother would be stimming by doing a lot of mouth sounds, and that threw me off. So, like, the drive home in and of itself was really stressful. So having space to be by myself and quiet, um, and also like I remember years that I had really a lot of trouble. I remember sitting in my dad's lap and him just holding me for a long time, and that was so good for so many reasons. Um, So a lot of times for me, it was I need a big squeeze. That may have something to do with the undiagnosed autism, but I think sensory issues are very similar with ADHD as well. Um, Yankin Zhao said, should we tell kids the truth about ADHD? Oh my gosh, yes. Do not lie to your child. One of the best things my parents did was the second that my kindergarten teacher suspected it and they got set up with testing was Mrs. Hamilton noticed that you're having trouble with focusing and you're very easily distracted. And we think that you might have something called ADD, because that's what it was called at the time. And I knew why I was going through the testing. I knew why I was taking the medicine. I knew how it affected me. And I was able to teach my classmates to the point where people would be like, guys, quiet, you're distracting Kate. Um, and so it's really important that you don't lie to them because they know they're different. They know that something is different. And if they don't know what it is, they think they're bad or wrong. Losing personal belongings. Okay, so Marciela, oh, I'm sorry, let me finish that. Haha. What is special about ADHD? We're creative, we are naturally out of the box thinkers. Um, it's like there's so many cool things. Like if I turned around my computer right now, this is my office and my craft room. And it is an explosion of creativity and things I have made, um, and things I've tried. I have learned so many things because everything is fascinating to me. Um, and I can connect to so many different things because I've learned so many different things and can see the interconnectedness. So yeah, there's some awesome stuff about ADHD. Now back to Maricel. Um, She was asking if we had suggestions for losing personal belongings. Oh my gosh. Um, I do well with having things in certain spots. My husband, who has really extreme ADHD, does not do well with that. So we've been using tiles. They are connected to like it's a little keychain or something that you put an app on your phone and it'll make it ring, right? One time I accidentally put his wallet in the fridge and we couldn't find it for days because the fridge acted like a Faraday cage and didn't make the tile ring. But having a place for something and being almost ridiculous about putting it where it's supposed to go, right? Because I've lost my debit card because I put it in my back pocket when I was pumping gas instead of putting it back in my wallet. And when I finally got around to doing laundry, I was like, oh, I've already canceled this one and ordered a new one. Everyone has some sort of ADHD, and since we're not exerting enough effort, ha, yeah. I have a lot of thoughts about that and putting saying everyone has some sort of ADHD. Um, I'm trying harder than anyone to do a lot of these things. And I also thought that some of my workarounds were things that were extra wrong about me, like not reading all the stuff for our assignments. I remember recently talking to my graduating class about I didn't always read our homework assignments, but I still did well. And they're like, who reads? And I thought that it was something that I did wrong, but it turned out everyone was doing it. So I think less about saying, hey, you're wrong to say that, but more about being like, you know what? I know who I am because I can't handle anyone else. Yeah, being able to lock a card now is much easier. Um, okay, any other questions?
Well, thank you so much, Kate, for sharing your personal story. This was so helpful to see it like in someone's everyday life and kind of get it from the perspective of someone who has that lived experience. Like we have all the knowledge that was shared from the previous speakers, and then seeing it, how it impacted your own life was really helpful. So we do appreciate you being willing to share your personal story and your lived experience with us.
I did forget one thing that I really wanted to
Sure.
point out. So I was one of those kids that had trouble with appetite with my stimulants, and I was incredibly underweight throughout my entire life. And it turned out that we hadn't been asking the right questions, and I had like textbook acid reflux. And once we figured that out and were able to control it, I was able to gain weight at a normal rate. So um, paying attention to those possible co-occurring issues is really, really important too. So,
Absolutely.
yeah.
Yes. No, it was so helpful. We really do appreciate it. So thank you so much, Kate. Okay. So we are going to look over at, I think Mandy's going to share for us right now. So obviously, thank you so much for attending, but we want to make sure that you take a moment to visit the link that's on your screen before you leave today's event. And we ask that you complete that evaluation. There's the QR code for you. If you have the PDF, if you got that at the very beginning, there's also a link that you can click on. I don't know if we can share that in the chat. That might be helpful. But please make sure that you make note of the email that you're using when you complete this evaluation form. And the reason for that is because when you submit your completed evaluation, the CEU certificate is then going to be sent to that email address that you've entered. So that way you can access it and print it later. We do take your feedback seriously. This helps us to plan the topics, speakers, themes, and format of our future workshops. We will obviously want to make sure that we notify everyone when this recording is available. Sometimes there's a little bit of a lag, but we do get the recording and then we will post it on the website to make sure that you're able to share it with anyone that you think might want to view the workshop. We do appreciate and thank you so much for your attendance today. And we look forward to seeing you at our next wellness workshop in February, where we're going to be discussing attachment styles. So just another reminder as you guys are completing this and getting your links together and making sure you have that to get your CEU. We just want to give another big, huge thank you to our speakers again for taking time to share their expertise with us. And thank all of you for joining us today. We're going to keep this window open for a little bit longer just to make sure that everyone has a moment to complete their evaluation. But once you're done, feel free to log off after you complete that evaluation. And we hope to see you, like we said, again at our next wellness workshop in February.